Hello? Hello, everyone. Thank you all for joining. We will begin our session shortly. If I'm audible, can you send me a message and pop it up in the live chat? Am I audible? Hello? All right. I think I'm audible. Thank you so much. We will begin the session shortly. So, आज is our second day of discussing CVS Pharmacology. We have already discussed three major portions of your CVS Pharmacology the day after. ठीक है and the day before I'm saying परसों हमने discuss किया था mainly and that discussion was mainly on your cardiac glycosides and drugs for heart failure. Then we discussed something about the vasodilators, vasoactive peptides as well as nitric oxide, and then we finished even discussed your drugs acting on the renin angiotensin aldosterone system, that is the RAS mechanisms पे जो भी drugs which were acting. So today आज जो मेरा discussion का जो main topic है that includes your anti-angina drugs. So we'll be going through that. We will also be going through anti-arrhythmic drugs, and then we'll conclude our session with just a brief discussion on the drugs acting on the kidney. That includes your diuretics and your antidiuretics. We have a lot to cover today, so I'm trying to go a little bit faster so that we can conclude all of CVS pharmacology, including your renal pharmacology as well. That is diuretics as well as antidiuretics in one session. Purposefully, I'm not discussing hypertension today because the major drugs that we use in hypertension, we have already discussed that in the relevant sections. So the today जो आज जो major drug that was left was your diuretics. So today we'll be going over the diuretics. So पूरा hypertensive drugs we've already studied, including our discussion on the beta blockers as well. So we will not be discussing antihypertensives per se, but I would suggest that we go through all of these drugs that we have read till now, and then we study hypertension from medicine first. And that would be my approach to study hypertension. Instead of going through the chapter that is in there in your pharmacology textbooks, I would suggest that हम सारे पहले drugs जो कि hypertension में हम देते हैं, we just go over that, and then we look into the medicine part of it, and then उसके accordingly जो भी हमारी newer guidelines है of your treating hypertension, we shall be following that. So that will be a discussion of some other video. So today we'll not be discussing that, especially in case of your examinations. I would say most of the questions that come for your second year examination students, whoever are going for second year examinations, I would say please focus on medicine part of it as well. So I'm just gonna wait for 2 more minutes and then we are going to start the session. I think we should start right now. Thank you everyone for joining. जो भी बाद में session join in करेगा and you can follow it up as well. So I'm going to go a little bit slower now. Abhi we're not jumping into the drugs straight away. So the first topic of our discussion today is anti-anginal drugs. So before discussing something about before discussing something about the drugs that we give in an angina, it wouldn't hurt if we just discuss about the different types of angina and ischemic heart disease in proper. So, what is ischemic heart disease? So, ischemic heart disease is just a group of clinical pathological syndrome. This may we are seeing an imbalance between the oxygen supply and demand. So, you call it as the oxygen demand supply mismatch. Okay. So, what is happening is the oxygen demand is going up and the oxygen supply is going down. Okay. So, that is your ischemic heart disease का major mechanisms. And as you guys know, हमारा जो left ventricle है, that is more predisposed to develop an infarct. And why is that? Because it's more thick. It's going to have increased amount of tension generation. Because हमें पता है that the aorta में whatever diastolic blood pressure we have to achieve so that हमारा aortic valve open हो जाए, that is considerably more, right? That's about 80 millimeters of mercury. Whereas with same things when I'm going to say it for the pulmonary artery, it's only 8 millimeters of mercury. So as you can see, हमारी impedance जो है that we have to match for in case of an aorta is much more. The left ventricle thickness is much more. And as you guys know, what's going to happen is हमारा जो blood जो heart है mainly, it is predominantly supplied during diastole. ठीक है? So that is a very important concept. What happens during systole कि हमारा coronary blood flow is arrested. So let me just tell you. So जो हमारी blood vessels है in case of your heart, we have the epicardial vessels, then you have these penetrating vessels, and अंदर की तरफ we have the subendocardial vessels. ठीक है? So what's going to happen during systole is the heart is going to contract inwards, and जो मेरी subendocardial vessels हैं, they're going to get stenosed. And उसके कारण I'm going to see basically impedance in your blood supply during systole, and that is known as the subendocardial crunch. Okay, so that's known as the subendocardial crunch, and that is the reason why whenever we are going to discuss ischemic heart disease, it mainly starts from your subendocardial portion and then it goes outwards, and ultimately we have formation of a transmural infarct. Okay, so as you guys all know, if it's a subendocardial infarct only, we get something known as non-ST elevation MI, and if it is a transmural infarct developing, we get something known as ST elevation MI. Okay, so let's just see. We have different causes of your ischemic heart disease. We'll just be going over it very quickly. So the first thing is an atheroma. That's an atherosclerosis का result है. So we know an atheroma, what is it composed of? It's composed of an endothelium. It's composed of a fibrous cap. We have foam cells, that is macrophages and smooth muscle cells, which are laden with lipid, especially your oxidized LDL. Okay? We have the lipid core and we have the neovascularization occurring at the periphery. So the different types of plaques that we have is, first plaque is a stable plaque. Why am I going to call it as a stable plaque is, इसमें what's going to happen is the patient is going to develop symptoms of angina when a coronary blood vessel का more than 70% of its lumen is obstructed. Okay, so that patient will have ischemia when obstruction exceeds more than 70% of the vascular lumen only during exercise. Okay, when it occurs more than 90% of the lumen diameter, the patient is going to experience ischemia at rest. Okay, so that is an important thing. So a stable angina, and जो plaque है मेरा, that is known as a stable plaque. Why is it stable? Because उसका fibrous cap is very strong. The amount of lipid that is in there is very less. The neovascularization is very less. Okay, all of these structures SARA make up a stable plaque. Then there's something known as a dangerous plaque, or also known as an unstable atherosclerotic plaque. इसमें what are the characteristic features? I don't have a fibrous cap. It's a very thin fibrous cap. More amount of macrophages, more amount of lipid is there. Okay, and what can happen is this dangerous plaque, it can undergo something known as acute plaque disruptions. Yeah, acute plaque changes. So what are they? We can have an erosion or an ulceration. Okay, जिसमें endothelium is getting removed. So that is known as erosion or an ulceration. The second thing that we can have is we can have fissuring or a rupturing. जिसके कारण what you're having is endothelium तो expose हो ही रही है, but you're also having release of your highly thrombogenic intraplaque lipid material. So इसमें lipid also coming outside. So that is known as a fissuring or a rupturing. One we can have something known as erosion and an ulceration. And both of these will lead to release of these pro-thrombogenic materials that are present in the lipid core, and that will lead to platelet adhesion and formation of a thrombus or an embolus. Okay? So that is known as fissuring or a rupturing. Fissuring, I would say, it occurs over a narrow area, whereas rupture is a more of a wider area. Okay? So as you know, platelets here mainly it will stick to the dysfunctional endothelium, and we have already studied in your blood physiology how is all of that mediated. Okay, the second thing is the platelet is going to release your platelet aggregated factors from both of the alpha granules as well as delta granules, and what's going to happen is it's going to undergo coagulation, and जो पूरा हमारा जो pathway, whether it is extrinsic pathway, intrinsic pathway, Both of them are going to lead to conversion of your fibrinogen into fibrin, and then we are going to have formation of a thrombus. That is platelet plug plus coagulation, that's going to form a thrombus. Okay. What else is an acute plaque disruption? We can have hemorrhage. As I told you guys, ये जो plaque के shoulder पे you have new vascularization developing. ठीक है, नए vessels are getting developed. So what's going to happen is whenever shear stress is going to be there, ठीक है, मतलब shear stress whenever the blood is flowing through that, turbulent blood flow हो रहा है, shear stress जब लगेगा, so these vessels are very friable because they are very newly formed blood vessels. And what can that lead to? It can lead to intraplaque hemorrhage. और जैसे intraplaque hemorrhage होएगा, more amount of vascular lumen will get obstructed. So that is another type of an acute plaque change. ठीक है. Just remember, statins जो हैं, we call them as they have pleiotropic effects. ठीक है. So it's not only the lowering of your blood lipids, that is the main role of your statins by inhibiting the enzyme HMG-CoA reductase, but mainly statins have some pleiotropic effects as well. matlab they're going to increase the stability of the plaque, they're going to have decreased activity of the macrophages and the releases of your matrix metalloproteinases, which are going to cleave your different amount of elastin or your collagen fibers. Okay. And they may also regress the plaque. So this is what I call as the pleiotropic effects of your statins. Okay. What else? We can have an atheroembolism as well. मतलब क्या हुआ? यहाँ पे मेरा thrombus बना है. Now it's going to embolize and block a smaller vessel. So these are the acute plaque changes that can occur. Okay. Now let me just tell you about the different types of different types of angina do we have. So what is an angina? पहला characteristic thing is the time duration. The time duration of an angina is usually about less than 20 minutes. When it is more than 20 minutes, some books में 15 minutes है, then I'm going to call it moving towards your MI, myocardial infarction. ठीक है. पर मायोकार्डियल इन्फेक्शन का डायग्नोसिस तब तक नहीं बन सकता टिल वी डोंट हैव द कार्डियक एंजाइम्स. ठीक है. सो व्हाट इज एंजाइना? इट्स अ चेस्ट डिस्कम्फर्ट. ठीक है. इट मे बी पेनफुल, इट माइट नॉट बी पेनफुल, and it might be perceived as only as a chest discomfort. So what are the different situations that we have? The patient can complain of a feeling of pressure or weight on the chest. So the patient says that as if an elephant is sitting on his chest. Okay. He may describe it as a squeezing type of pain or a burning sensation, and sometimes he may also use a clenched fist to describe the pain, and that is known as the Levine sign. Okay. Just remember, the nerve supply to the heart is C8 to T4, and due to this radiation, this pain can lead to radiation to it, to the inner side of the left arm, the jaw, the neck, or even both arms. Okay. And very importantly, so this is the mechanism of your referred pain, and we already know that. Okay. So there are some precipitating factors of your angina. One would be a heavy meal. Heavy meal leads to activation of your parasympathetic nervous system, and that can lead to splanchnic vasodilatation. So मेरा सारा का सारा blood is going into the gut instead of going into the heart. So इसके कारण I might get precipitation of an angina. What else? Walking against a cold wind. Because whenever I walk against a cold wind, दो चीजें होंगी. First, it's a form of an exercise only, and that can lead to tachycardia. And we've already studied whenever heart rate increase hota hai, it occurs at the cost of your cardiac cycle ka duration. And which portion of the cardiac cycle gets preferentially affected? It's mainly your diastole. And I told you guys कि मेरा जो myocardium है, when is it getting supplied by the blood? It's mainly getting supplied during diastole. So one reason is that. ठीक है. The second reason is whenever we walk against a cold wind, हमारी vasoconstriction होएगी of your cutaneous blood vessels, and that will lead to increase in the total peripheral resistance. मतलब basically an increase in your afterload. So this is the amount of load that the heart has to contract against. Okay, so that is not good for us. So that's going to increase your oxygen demand as well and shift the ratio towards कि demand ज़्यादा है, supply कम है. Okay, and that is what is known as angina. Okay, so this is all the precipitating factors. What are the different types of angina do we have? We have something known as stable angina. Okay. What is the stable angina? मतलब कोई precipitating factor होगा. ठीक है. मतलब it is not occurring at rest. There is always a precipitatory factor which is present. What are the different precipitating factors? It could be exertion, it could be emotional stress, heavy meal, I've talked about that, and walking against a cold wind. What are the characteristics of your stable angina? It is relieved by taking rest, and second of all, it is relieved by taking nitrates. Okay, very important characteristic difference. हमेशा the rest of the aspects of your angina will be similar. Okay. Just remember guys, a very important thing that I have to clear in your mind is जो हमारी atherosclerotic lesions होती है ना, they are known as fixed obstructions. मतलब whenever an atheroma is developed in a blood vessel, usually वो जो blood vessel affected है ना, that will not undergo vasodilatation. ठीक है. It's going to be fixed. मतलब if I am saying, if someone asks you what is the predominant effect of your nitrates in relieving angina, we don't have to jump onto and say कि भाई because it's a vasodilator and that can lead to vasodilatation of your coronary blood vessels, and ये answer ठीक होगा, that would not be right. It might play a role definitely, but the major role of your nitrates is not due to dilatation of your coronary blood vessels. ठीक है. What is the main वो क्या है? main reason the nitrates alleviate your pain and angina is by leading to venodilation. The veins को preferentially वो ज़्यादा करेगा dilate, and that is might be due to the one reason might be कि जो mitochondrial aldehyde dehydrogenase enzyme है which converts this NTG हो गया या फिर isosorbide mononitrate or dinitrate into releasing your nitric oxide. This enzyme mitochondrial aldehyde dehydrogenase is preferentially located in the veins. So मतलब venodilation is going to be the predominant action. और whenever venodilation होगा मतलब capacitance of my venous system is going to increase and I'm going to see pooling. So all of the blood is going to get pooled, and जो भी ये blood है it's not going to go into the heart, मतलब the preload is going to decrease. And whenever I say whenever the preload is decreasing according to Frank-Starling mechanism of the heart, the contractility will obviously decrease, and whenever the contractility decreases oxygen demand decreases, and उसके कारण जो supply mismatch ratio है that gets corrected. So this is what I would tell you, ये main हमारा mechanism है of nitrates. ठीक है. Some people say that that can lead to a phenomenon known as coronary steal. ये nitrates के केस में इतना ज़्यादा observe नहीं है. What is that, guide? Coronary steal क्या है? We're going to study a dipyridamole. ठीक है. हम so watch out for that as well. Coronary steal phenomenon क्या है? The second type of angina that I have is Prinzmetal angina, also known as a vasospastic angina. So इसमें क्या हो रहा है mainly? The thing is there is no precipitating factor, so it can occur at rest. It can occur at rest. ठीक है. एंड जो अंडरलाइंग कॉज है एंड व्हाट इज हैपनिंग इज यहाँ पे कोई एथ्रोमा नहीं है, अगर है भी है तो इट्स माइट बी वेरी स्मॉल. ठीक है. सो व्हाट इज हैपनिंग इज आई एम गोइंग टू सी वेजोस्पाज्म. मेरी कोरोनरीज आर वेरी अनस्टेबल एंड उसके कारण उस अनस्टेबल कोरोनरी टोन के कारण आई एम हैविंग वेजो कंस्ट्रिक्शन और पूरी की पूरी ब्लड वेसल्स कोलैप्सेस अपॉन इटसेल्फ. जब पूरी की पूरी ब्लड वेसल्स कोलैप्सेस अपॉन इटसेल्फ आई एम गोइंग टू सी अ ट्रांसम्यूरल इन्फार्क्ट. ठीक है. एंड नॉट अ सब एंडोकार्डियल इन्फार्क्ट, पूरा का पूरा जाएगा. ठीक है. सो मतलब व्हाट आई एम सेइंग इज some people would like to ask you what are the differential diagnoses of your ST elevation MI, mainly ST elevation in ECG. One of them is Prinzmetal angina, because Prinzmetal angina can lead to ST elevation. And why is ST elevation occurring? Because it's a transmural ischemia that is happening. But if you're going to check for your cardiac troponins, they're going to be normal. Why? Because it's angina and not myocardial infarction. Okay? When you perform an angiography in these patients, that's going to be absolutely normal. ठीक है. मतलब it's a one time phenomena. कई बार होता है. वरना if you perform an angiography after the pain has subsided, you will not find anything. ठीक है. As opposed to something known as stable angina, जहाँ पे आपको कुछ ना कुछ constriction या कोई ना कोई block in case of an atheromatous plaque मिल सकता है. ठीक है. So this Prinzmetal angina is more common in case of females, and just remember guys, it's more commonly in the right coronary artery, and इसके कारण we're going to see ST elevation mainly in your inferior wall leads, that is 2, 3 and AVF. That makes sense. इसमें guys very important thing is we would like to give something known as beta blockers in case of angina, because beta blockers क्या करते हैं? They decrease the myocardial stress. ठीक है. मतलब basically contractility reduce करके oxygen demand ratio को वो correct करते हैं. But इस case में the beta blockers are contraindicated. ठीक है. Beta blockers are contraindicated in vasospastic angina. And why is that, guys? Because इसमें जो main mechanism है, that is not the demand mismatch ratio. That is mainly what? That is mainly I'm seeing vasoconstriction. ठीक है. I'm seeing vasoconstriction. So if I'm going to give a beta blocker, that's going to block your beta 2 receptors, and we know beta 2 receptors mainly mediate vasodilation. So जो भी हो रही थी vasodilation due to beta 2 action, that will further get depressed, and I'm going to see what? और ज़्यादा adrenaline mediated vasoconstriction होएगा, and the patient is going to die. ठीक है. So that is the important thing. Beta blockers are not given in Prinzmetal. So Prinzmetal में what are the drug of choice then? The drug of choice is your calcium channel blockers. We can use nitrate, but if someone would like to ask you, the calcium channel blockers are the drug of choice, especially your dihydropyridines. ठीक है. DHP drugs. ठीक है. What about this unstable angina? Unstable angina is a part of acute coronary syndrome. और जो भी हमने acute plaque changes discuss किए थे guys, जो भी थे erosion, ulceration, fissuring, rupturing, intraplaque hemorrhage, atheroembolism, platelet plaque formation, thromboembolism, vasoconstriction, all of these acute plaque changes will occur in an unstable angina. So what is happening? Why do I call it as an unstable angina? Because it is unstable as it may transition to your myocardial infarction. ठीक है. As compared to a normal angina, that is stable angina, इसमें pain ज़्यादा severe है, इसमें pain ज़्यादा prolonged है. It is a precursor of your non-estivation MI, and this pain will characteristically be not relieved by your nitrates or rest. मतलब ये MI जैसा है. Only thing that distinguishes unstable angina for non-estivation MI is your cardiac troponins and your cardiac enzymes. ठीक है. So that is the main thing. So if I say MI में सीरम जो हमारे सीरम ट्रोपोनिन टी है, कार्डियक ट्रोपोनिन टी और ट्रोपोनिन आई, दैट इज गोइंग टू बी इंक्रीज. बट अंजाइना में इफ इट इज योर अनस्टेबल अंजाइना, इट्स नॉट गोइंग टू बी प्रेजेंट. ठीक है. एमआई में आई एम गोइंग टू टॉक अबाउट इरिवर्सिबल डैमेज व्हिच इज अकरिंग. अंजाइना में इट्स ओनली रिवर्सिबल सेल डैमेज. मतलब अगर मैं कोई इंटरवेंशन करूंगा देन माय मायोकार्डियम गेट्स सैल्वेज्ड. ठीक है. All right, so let's just discuss the anti-angiogenic drugs proper. What are the drugs do we have? We have nitrates and nitrites, वो हम discuss करेंगे. We have beta blockers and we have your calcium channel blockers, and we have some normal anti-angiogenic drugs which we're going to discuss that as well. ठीक है? So ये मेरे main drugs हैं nitrates, and I have your CCBs and your beta receptors. So let me just tell you some important things at the onset. Mainly the decreased preload. So that is the main thing. So decrease in cardiac oxygen demand by reducing the preload. According to Frank's Starling mechanism of the heart, I'm going to see a decrease in the cardiac tension generated. उसके कारण मेरी oxygen demand is also going to be less. What about calcium channel blockers? यहाँ पे mainly they work both ways. They reduce the cardiac contractility and they also reduce the afterload. Because many calcium channels are present at the smooth muscles and in your vascular smooth muscle cells in your blood vessels, तो blood vessels को dilate करेंगे, ठीक है? Because calcium mediates what? It mediates vasoconstriction. Calcium blockers will what will they do? They will lead to vasodilatation. So that is one thing. And beta blockers क्या करेंगे? They will decrease the cardiac oxygen demand by reducing cardiac contractility and rate. हमने already discuss किया है. Especially we would like to give your cardioselective beta blockers. ठीक है? Right. So let's just see. So these are the nitrites which we have available with us. We'll discuss NTG and we'll discuss isosorbide mononitrate and isosorbide dinitrate. So let's just see that. The mechanism of action we've already done very importantly. हमने बहुत अच्छे से किया है. So let me just surmise it very fast for you. So you have arginine. As you know, guys, arginine जो है, it gets converted to citrulline, and this releases nitric oxide. Okay, and we have multiple mechanisms. Even if you remember, guys, acetylcholine mediates vasodilatation of the blood vessel by directly acting of the endothelium, and that is the reason why nitric oxide, which is produced by the endothelium, उसे मैं endothelial derived relaxing factor भी कह सकता हूँ. ठीक है. एंड व्हाट ये जो मेरी एंडोथेलियल सेल्स है इसमें कौन सा टाइप ऑफ सब टाइप ऑफ नाइट्रिक ऑक्साइड सिंथेस है? इनॉस. ठीक है, वी हैव ऑलरेडी डिस्कस दिस. सो दिस नाइट्रिक ऑक्साइड इट डिफ्यूजेस इनटू द स्मूथ मसल सेल, इट एक्टिवेट्स योर गोनल साइक्लेज. उसके कारण आई एम गोइंग टू हैव डेवलपमेंट ऑफ योर साइक्लिक जीएमपी. नाउ साइक्लिक जीएमपी लेवल्स आर गोइंग टू गो अप. ठीक है, एंड वी हैव ऑलरेडी डिस्कस पहले भी, साइक्लिक जीएमपी इज गोइंग टू स्टिमुलेट योर प्रोटीन काइनेज जी. ठीक है, and what will that going to do? That's going to activate your enzyme, that is myosin light chain phosphatase. ठीक है, MLCP, which is going to be active and phosphorylated. And what will that do? जो भी मेरी myosin light chains हैं which are phosphorylated, उन्हें वो क्या कर देगा? myosin light chains में convert करेगा which are unphosphorylated, and इसके कारण I'm not going to see any contraction. So that is in a nutshell what is the main mechanism of your nitric oxide. ठीक है, so let's just see, and we have already discussed all of this, what are the different type of nitric oxide synthesis as well. ठीक है, just remember guys, why am I calling it as a venodilator? Mainly ये जो सारी happening है venous, I'm going to see venous dilatation predominantly and not arteriolar dilatation in case of your nitrates. Why is that happening? Because एक enzyme है which is known as mitochondrial aldehyde dehydrogenase. This enzyme is more present in the veins, and this is the enzyme which is going to convert a glyceryl trinitrate and give it to release nitric oxide, or it's going to convert your isosorbide mononitrate or dinitrate and give it to release nitric oxide. So जो पूरा mechanism है, this enzyme mitochondrial aldehyde dehydrogenase mediate करता है, and this enzyme is more present in the veins. ठीक है, that makes sense. Just remember guys, one more thing, preferential dilation of the epicardial conducting vessels are occurring and not the autoregulatory arteries. What do I mean by that? That is, see guys, so we can have these conducting vessels, हमारी बाहर epicardial conducting vessels which are going to bring blood to every portion of the heart. ठीक है, I have a portion which is ischemic, all right, and I have a portion which is normal. ठीक है, what's going to happen is whenever ये जो ischemic portion है, it's going to release some mediators, especially adenosine I would say. ठीक है, it's going to release a mediator which is known as adenosine, and what happens is जो इसकी blood vessel है जो इसे supply कर रही है, that undergoes vasodilation so that more amount of blood can come in. अगर nitrates, due to they have a very good action, why? Because nitrates leads to vasodilation here. ठीक है, मतलब at the conducting vessels. ठीक है, whereas we have some drugs, I will like to tell you the drug that is dipyridamole. ठीक है, ये जो drug है ना dipyridamole, it doesn't work on the conducting vessels that well. It mainly occurs here. It mainly works on the resistance vessel. उससे प्रॉब्लम क्या हो सकती है? जो मेरा प्रोटेक्टिव मैकेनिज्म था कि मेरे इस्कीमिक सेल्स ने एडेनोसिन जनरेट किया था एंड दे डाइवर्टेड मोर ऑफ द ब्लड टू देम. व्हाई वाज दैट हैपनिंग? दिस इज नोन एज ऑटो रेगुलेशन. बट अगर मैं कोई ऐसा ड्रग यूज करने लग जाऊं, इट्स गोइंग टू lead to vasodilation even in non-ischemic zones because it works on the resistance vessel, then that is going to be harmful. और इसे मैं coronary steal कहता हूँ. The nitrates are good because nitrates dilate the conducting vessels and not the resistance vessel or not the vessels which are undergoing autoregulation. So this is important. ठीक है, mechanism of action हमने already बात कर ली है guys. Alright, one more thing is ये जो nitric oxide है uh, this is very important in the platelets as well. So it is also going to play a role in your anti-aggregatory action as well. Okay, very importantly, it's going to have an anti-aggregatory action on the platelets. So nitric oxide and PGI2, that is prostacyclin, they basically inhibit your aggregation of your platelets. Okay, very importantly. All right, guys, we've already talked about this fixed obstruction wala thing, and mainly it is the reduction in your preload that is leading to alleviation of your pain in your angina. Okay, that makes sense. All right, guys. So let's just see some of the pharmacodynamics of these nitrates and their congeners. हमने already बात की that there is marked relaxation of the large veins. ठीक है, उसके कारण I'm going to see a decrease in the preload. अगर preload कम होएगा, obviously I'm going to see a decrease in the stroke volume and a decrease in a cardiac output. That makes sense. There is decreased blood pressure, but only slightly because it mainly works on the veins and not on the arterioles. Just remember, guys, there is going to be improved perfusion of your subendocardial regions. ठीक है, वही हम बात करें conducting vessels का mainly vasodilation हो रहा है, that can happen. ठीक है, but mainly not the resistance vessels. So there's going to be improved perfusion of your subendocardial vessels. ठीक है, what else? पर यहाँ पे सिर्फ action fix नहीं होता है. This nitric oxide can work at other sites as well. For example, it can work at the skin, it can work at the brain. In इसके कारण meninges vessels may undergo vasodilation, and hence one of the side effect of using your nitrates is headache. ठीक है, there's going to be headache, and अगर face पे हो रहा है, I might see facial flushing and all. Skin पे हो रहा है तो facial flushing and your headache can happen. ठीक है, लार्ज एपिकार्डियल वेसल्स जो है वो मेनली डायलेट हो रही हैं, इस करके ऑटो रेगुलेशन इज नॉट इम्पेयर्ड. दैट मेक्स सेंस. ठीक है, नाउ अ वेरी इंपॉर्टेंट थिंग इज बिकॉज रिलैक्सेशन अगर हायर डोजेज में यूज करते हो बट नॉट एट द थेरेप्यूटिक डोजेस, इट माइट लीड टू रिफ्लेक्स टैकिकार्डिया एंड पोस्टुरल हाइपरटेंशन. व्हाई इज दैट हैपनिंग? बिकॉज पहली बात, सारे के सारे ब्लड वेसल डायलेट कर जाएंगे तो आई एम गोइंग टू सी पोस्टुरल हाइपरटेंशन, and whenever the blood pressure decreases I might see reflex tachycardia, but usually this is not so prominent. ठीक है, all right. So what are their other actions? They lead to relaxation everywhere. That is either in your bronchi, they lead to relaxation of your biliary system as well, they lead to relaxation of your gastrointestinal system as well, and they lead to relaxation of your genitourinary system. मतलब सारे के सारे vascular smooth muscles को relax करेगा via nitric oxide. I told you about the decreased platelet aggregation due to nitric oxide as well. A very important thing, guys, is this nitric oxide generates methemoglobin. ठीक है, and we might have methemoglobinemia. ठीक है, so this is important. जो ये nitrates है, they may lead to development of a methemoglobin. ठीक है, all right. So what are the pharmacokinetics? Usually जो इन्हें देते हैं हम, usually we take it as a sublingual route. Oral में mainly हमारे पास एक ही drug है, that is isosorbide mononitrate. So they say oral में bioavailability is very less, but there is only one drug which can be given orally, that is isosorbide mononitrate. जो रह गए हैं, that is isosorbide dinitrate or your glyceryl trinitrate, GTN. वो हम mainly we give it via the sublingual route, or we can use a transdermal patch. So they both of them have good bioavailability, but oral में I want you to remember isosorbide mononitrate has the maximum amount of bioavailability, that is 95%. वरना और सबका कम है. ठीक है, very important. Told you about the biotransformation. So all of this transformation is occurring in the liver. ठीक है, so all of the liver जो है more than 99% को biotransform कर सकता है. ठीक है, half life if you see they're very short acting drugs. ठीक है, sublingual NTG has a half life of 2 to 3 minutes. Whereas I told you guys, because oral absorption, अगर orally कुछ absorb होगा drug, that's going to have an increased amount of T half because it takes time to absorb as well. So oral जो हमारा isosorbide mononitrate है, it has a T half maximum that is a 4 to 5 hours. ठीक है. Now guys, a very important phenomena is your phenomena of your nitrate tolerance. हमने already discuss किया हुआ है कि what's going to happen is whenever I'm going to have this nitric oxide generation ना, this nitric oxide will lead to generation of free radicals. And these free radicals can inhibit the enzyme that is mitochondrial aldehyde dehydrogenase. So what is happening is, मेरा मान लो if I have glyceryl trinitrate, ठीक है, so this GTN was releasing nitric oxide due to this enzyme that is mitochondrial aldehyde dehydrogenase. But this nitric oxide will lead to generation of what? This lead to generation of your free radicals. And these free radicals itself can inhibit your mitochondrial dehydrogenase. So what's happening, guys, is जितना एक टाइम ऐसा आएगा जिसमें मैं आई एम स्टिल गिविंग द GTN, आई एम स्टिल गिविंग अ नाइट्रिक ऑक्साइड डोनर ड्रग, but still I'm not seeing the effect. So that is known as tolerance. And why is that happening? One theory says it's mainly of free radicals. The other theory says that we're going to have depletion of your sulfhydryl groups as the main reason. ठीक है, there is one more theory that says कि जो और हमारे जो compensatory mechanism है, that is sympathetic nervous system or your renin angiotensin aldosterone system, that is going to be mainly playing a role in your nitrate tolerance. तो इसके कारण what we are going to do is हम basically we ask the patient, especially when the patient is on chronic prophylaxis, अगर वो nitrate पे है, we ask the patient to do what? Nitrate free intervals. Usually overnight nitrate free intervals are very important for the patient. ठीक है, so mechanism of nitrate tolerance हमने already पढ़ लिया है. Alright, so we have seen कि frequently repeated exposure to nitrates lead to a decrease in most of their pharmacological effects, and ये जो tolerance है हमने already पढ़ ली है. ठीक है, So since tolerance appears rapidly and disappears rapidly, brief periods of no therapy, that is hours of overnight therapy, can be sufficient to permit your recovery. That makes sense. All right. But just remember, guys, nitrates can cause dependence as well. So one thing is tolerance, one thing is dependence. Dependence का मतलब ये है, we cannot stop the nitrates as it is. एकदम से stop नहीं कर सकते. Just like beta blockers, just like nitrates, just like steroids. So we are going to withdraw them slowly because it has been seen जब आप nitrates को immediately withdraw करते हो, the people might have an increased risk of a myocardial infarction. So withdrawal of nitrate should always be gradual. So this is the thing. We can have a translingual spray की form में भी आ सकता है GTN. We can have sublingual tablets of GTN. They're going to bypass the liver because sublingual routes here, they're going to prevent your first phase or जो भी हमारे metabolism है that's occurring in the liver. Then we can have in the form of a transdermal patch, but just remember patch must be taken out for 8 to 10 hours daily. And mononitrate जो है isosorbide mononitrate that is available orally. ठीक है? We know this. What are the adverse effects? It can lead to headache, throbbing headache. It may lead to dizziness, vertigo, lightheadedness, and it may lead to syncope or postural hypertension. ठीक है? What else? Cardiovascular system में we can have flushing of the face predominantly. The patient might also be experiencing your palpitations. ये सेम रीजन ही है कि मेरा पोस्टल हाइपरटेंशन जो है ब्लड प्रेशर कम होने के कारण आई एम गोइंग टू सी रिफ्लेक्स टैकिकार्डिया एंड दैट इज गोइंग टू बी मैनिफेस्ट एज योर palpitations. What else? I'm going to see postural hypertension. And just remember, guys, a very important contraindication of your nitrate use is concurrent use of a sildenafil within 24 hours. What is happening is this sildenafil is going to inhibit your phosphodiesterase type 5 enzyme, which was what it was degrading your cyclic GMP. So मेरे cyclic GMP के levels are going to go up. Nitric oxide is also leading to increase in cyclic GMP. Phosphodiesterase 5 inhibitor is also leading to increase in cyclic GMP. That will lead to severe vasodilation. Severe vasodilation के कारण I'm going to see a very tremendous fall in your blood pressure. Okay? And that might be dangerous for the patient. Okay? What else? We can have skin rashes, contact dermatitis can occur, especially with drugs like pentaerythritol, tetranitrate. So these are organic nitrates. Okay? Organic nitrates के साथ skin rashes and contact dermatitis has been seen. Methemoglobinemia is a very important side effect. Okay? So all of these are your, and withdrawal reactions हमने already पढ़ा है, under increased risk of MI that is occurring, we've already seen that. Alright, so what are the contraindications? I would like you to remember. Angina due to HOCM, that is hypertrophic cardiomyopathy, is an absolute contraindication for your nitrates. Constrictive pericarditis is a contraindication for your nitrates. Concurrent use of sildenafil within the last 24 hours is a contraindication of your nitrates. Severe mitral stenosis, severe aortic stenosis is also a contraindication of your nitrates. And all of these other conditions that you might remember, severe hypertension is also one. So all of these are your contraindication, I would say, precautions as well. Okay? Therapeutic uses of nitrates क्या है? Mainly giving it in angina pectoris. One thing is acute attack की termination को. उसमें we know कि nitroglycerin हम देते हैं. Usually we consume 0.5 milligrams, 3 tablets within 20 minutes. So this I want you to remember. 0.5 milligrams, 3 tablets within 20 minutes, and उससे we see whether the patient is having some relief or not. But we can also give chronic prophylaxis. अगर हमें chronically देना है, then we go for NTG either transdermal route से या oral nitrates like your isosorbide mononitrate. ठीक है? मेन एग्जामिनेशन मेन जो mechanisms of anti-anginal effect हमने already पढ़ लिया है. Exertional angina में it is mainly due to the decrease in your preload, and variant angina में it will be due to vasodilatation of your coronary vessels. ठीक है? Just remember guys about the stable plaque lesion that I was telling. ठीक है? Classical angina में हमारा main reason will be your decrease in preload, whereas in case of your variant angina it will be your increased myocardial oxygen supply. Right? ठीक है? So therapeutic uses और क्या क्या हैं? We can give it in heart failure, especially intravenous GTN can be given. ठीक है? So this may be given in your heart failure. All right. Okay. What else? We can have other things. MI may, it's very important. Okay. MI may we can give your IV nitroglycerin in more complicated patients. And just remember, guys, about cyanide poisoning. So what is that? What is happening is this: nitrates and nitrites they're going to form methemoglobin. हमने अभी पढ़ा. But we can exploit this in your cyanide poisoning. Okay. Cyanide poisoning. What's happening? I'm going to have cyanide. Cyanide has a very important affinity towards your methemoglobin. So methemoglobin combines with the cyanide, and then we're going to have formation of a cyan methemoglobin. अब हम क्या करेंगे? We're going to add another drug given from outside, that is sodium thiosulfate. उसके कारण क्या होगा? ये जो cyanide है, ये जो thiol group है उसके साथ जुड़ जाएगा, and we're going to have sodium thiocyanate का formation, which is relatively non-toxic and can be filtered by the glomerulus and lost in the urine. And that is the reason how we can give hydroxycobalamin in cyanide poisoning. We can give sodium thiosulfate and nitrates and your nitrates as well. Because sodium nitrate we would like to prefer in those cases. Why? Because GTN and all जो मेरे isosorbide mononitrate वगैरह हैं, इनमें they have a predominant vasodilator action. तो sodium nitrate का बहुत कम vasodilator action है. उसका जो main हमें चाहिए वो हमें nitrate group चाहिए उसका. ठीक है? So the next group of drugs is your beta blockers. हमने already cardioselective beta blockers के बारे में extensively पढ़ लिया था in your ANS pharmacology. So I'm just going to tell you कि they're going to decrease your cardiac oxygen demand, हमने mainly देखा, and they're even going to increase your myocardial perfusion. Why? Because they're going to decrease the heart rate, and उसके कारण I might see an augmented diastolic perfusion time. Heart rate कम होएगा तो cardiac system, cardiac जो cycle है उसकी duration will increase, and we know जब भी cardiac cycle की duration decrease होती है, in fact, so diastole is the one which is predominantly affected. So the opposite thing will happen here as well. Beta blockers, I told you that they're contraindicated here, variant angina. Okay, absolute contraindication. All right. So already seen कि cardioselective beta blockers are preferential. Okay, so metoprolol, carvedilol, and your labetalol. So these are the ones which are more given usually in case of that. Now we move on to the next set of that is your calcium channel blockers. ठीक है, so calcium channels हमें पहले पता होना चाहिए. Calcium channels हमारे पास दो टाइप के हैं. We can have your ligand gated calcium channels. We can have voltage gated calcium channels. अभी we are going to talk mainly on your voltage gated calcium channels. ठीक है, हमें पता ही है कि whenever जो cell का RMP है, when it's going to reach your specific voltage, mainly minus 40 millivolts or lower. When I say lower, it means a positive decrease in your resting membrane potential. तो मेरे channels होते हैं voltage gated calcium channel. They're going to open up. What are the different types of voltage gated calcium channels we have, and what are the different drugs which act on them? Let's see that. So mainly हमारे पास तीन है. So we have the L type of voltage gated calcium channel. L stands for long lasting. Okay, where are they present? Mainly present in the smooth muscle. They're present at the heart. They're present in the neurons. Okay. इनकी स्पेशल प्रॉपर्टीज क्या है लॉन्ग एक्टिंग की? दे आर लॉन्ग एक्टिंग डेफिनेटली, बट दे हैव अ हाई थ्रेशोल्ड, मतलब ज्यादा टाइम लगेगा. दे आर गोइंग टू हैव अ हायर थ्रेशोल्ड एज कंपेयर टू द अदर वंस. ठीक है, एंड व्हाट एल्स, inactivation rate इनका slow है, and that is the reason why they are long lasting. What are the different blockers that can block this L type of voltage calcium channel is? हमारे जो भी हम CCB जो आज पढ़ेंगे, that is your verapamil, DHPs and your diltiazem. ठीक है, the second type is your transiently opening, and you already guessed it, this T type of voltage gated calcium channel we studied it where? We studied in your SA node. ठीक है, so pre potential को जो complete कर रहा था, that was your T type of voltage gated calcium channels. Initially HCN channels का थोड़ा रोल था to bring it towards RMP, and then उसके से लेके minus 40 millivolts या minus 45 millivolts तक जो main action था, that was your transiently opening of your voltage gated calcium channel. So mainly they present at the SA node for the pacemaker activity. ठीक है, the T type of calcium channels are also present at the thalamocortical loops, and that is the reason why जो इसका blocker है वो ethosuximide and flunarizine है. As you might have guessed, ये जो ethosuximide है, we use it in case of absent seizures, because absent seizures में जो main predominant defect है, that is in your thalamocortical loops, जो कि बहुत ज़्यादा activate हो रहे हैं. ठीक है, right. And we have the N type which are present at the neurons. तो उसके लिए we have something known as your omega conotoxin, which is a blocker of this N type of voltage gated calcium channels. So this is the structure of your voltage gated calcium channels. इसमें बहुत सारे हमारे पास सब यूनिट्स है. तो मेन सब यूनिट जिसपे हमारा जो वर्क करता है, दैट इज योर अल्फा 1 सब यूनिट. Okay, so this is the one I want you to remember. They bind to the alpha 1 subunit of your voltage gated calcium channels. We have three groups actually CCBs में. We have the dihydropyridine, जिसका जो main prototype drug is your nifedipine. We don't use nifedipine usually. The second one is your benzodiazepine. This is not benzodiazepine, this is benzodiazepine. So the drug's name is diltiazem. And जो last मेरा group है, that is phenylalkylamine, that is including your verapamil. So मेरे तीन CCBs जो हैं, which are working on your L type of voltage gated calcium channels, and these are the ones which are going to study it in angina. We've already seen we have DHPs, we have verapamil, and we have diltiazem. Okay, so what are the different type of DHPs do we have? We have nifedipine, we have nicardipine, we have amlodipine, nimodipine, lacidipine, nitrindipine, and cilindipine. Okay, so ये हमारे different type of DHPs हैं. Whereas phenylalkylamine and your जो हमने already diltiazem हमने already पढ़ लिया. ठीक है, what are the different pharmacodynamics हमने already, ये important चीज है guys. Dihydropyridine, they only work on the vessels. DHPs, they only work on the vessels. Whereas verapamil and diltiazem, they block calcium channels both in the vessels and at the heart. Very important thing. Okay? DHPs are not going to work at the heart. Verapamil and diltiazem predominantly are going to work at the heart. Okay? But they're not, they might even work at the blood vessels as well. So this is an important difference that I want you to tell. So what are the different actions of your CCBs? Let's see. अगर हम कार्डियक CVS की अगर हम बात करें, तो अगर हार्ट पे इफेक्ट है, सो व्हाट इज दैट? डिक्रीज कंडक्शन. ठीक है, सो देयर इज डिक्रीज कंडक्शन इन योर स्लो फाइबर, दैट इज मेनली योर एबी नोड. तो ये एबी नोड को ब्लॉक कर रहे हैं सॉर्ट ऑफ, दैट इज द फर्स्ट थिंग. देन आई एम सीइंग इंक्रीज रिफ्रैक्टरीनेस. ठीक है, रिफ्रैक्टरीनेस इज गोइंग टू बी इंक्रीज. व्हाट एल्स? दिस इज गोइंग टू बी डिक्रीज्ड ऑटोमेटिसिटी, मेनली इन योर इस्कीमिक जोन. सो दिस इज वेरी इंपॉर्टेंट फॉर अस. जो भी हमने ऑटोमेटिसिटी जनरेट किया है ड्यू टू इस्कीमिया, बिकॉज वी नो इस्कीमिया लीड्स टू व्हाट? इट लीड्स टू डीपोलराइजेशन. ठीक है, इस्कीमिया लीड्स टू डीपोलराइजेशन. तो उसके कारण जो भी ऑटोमेटिसिटी डेवलप हो रही थी इन अदर टिश्यूज, इक्ट्रोपिक टिश्यूज, वो सप्रेस करना इसका जॉब है. ठीक है, एंड व्हाट एल्स? decrease of your cardiac contractility. ठीक है, ये verapamil and diltiazem can only affect the heart, so these are the actions that they do. They're going to decrease the conduction of the AV node. They're going to increase the refractoriness, मतलब effective refractory period सबके increase करेगा. They're going to decrease the automaticity in the ectopic foci, and they're going to decrease your cardiac contractility. That is your negative inotropic effect. What about the vascular actions? Mainly vascular actions सारे calcium channel blockers करते हैं, पर उसमें भी DHPs are the ones which are going to predominate. पर ऐसा नहीं है कि verapamil and diltiazem cannot follow. ठीक है, so very important. So what do they do? They mainly lead to vasodilation, mainly in your arterioles now, not in the veins. ठीक है, अब उल्टा हो रहा है. जो हमारे एनोडोनस थे, they were mainly in your veins. Now इसमें we are seeing vasodilation mainly in the arterioles. ठीक है. And one more action is some of these drugs like nitrindipine, for example, N for nitrindipine, they release nitric oxide as well, and that is the reason why they might even have a further potentiation of your vasodilation. Okay, all right guys, so just see guys, so ये मेरा structure है of your voltage gated calcium channels. As you know, we have different states of your voltage gated calcium channel. So what is the state? This is known as the closed state. Then we can have something known as the open state, and we can have something known as the inactivated state, जिसमें मेरा ये gate यहाँ पे अटका हुआ है. So what are they going to do is, ये जो transition है ना from your mainly what happens is कि closed gate जो है it might get activated, and whenever it gets activated it further gets inactivated. ठीक है, inactivated से वापस into the resting state जाना, ठीक है, इसे ये inhibit करते हैं, that is verapamil and diltiazem. So they're going to mainly inhibit the recovery of these inactivated calcium channels back into their closed state or their resting state. ठीक है, so very important thing. Alright, so ये हमने देखा कि verapamil, nifedipine और diltiazem को अगर हम कंपेयर करें, ठीक है, so just see frequency dependency of your channel blockade. What is that? कि जितनी जितनी ज़्यादा higher frequencies पे channel blockade will also increase, and you can guess why. Because जितनी जितनी higher frequencies पे मतलब more amount of inactivation is going to alternate. And इस करके more amount of calcium channels are going to be there in an inactivated state, and इसके कारण मेरी CCBs can bind to that inactivated state. ठीक है, and prevent its recovery. ठीक है, so frequency dependent blockage mainly verapamil का है. कार्डियक इफेक्ट्स मेनली verapamil एंड diltiazem दोनों के हैं, उसमें भी verapamil के ज्यादा हैं. अगर आप vascular smooth muscles की बात करो, it is mainly the DHPs followed by verapamil and the least by your diltiazem. ठीक है, clinical use अगर हम बात करें, verapamil and diltiazem in mainly used in arrhythmia. ठीक है, it might be used in hypertension and angina as well. Whereas मेरे जो nifedipine and all है, they might be used in your peripheral vascular disease, one that is Raynaud's, or it might be used in hypertension as well. ठीक है, मेन इनके actions यही हैं. Right. So what are their other actions? Mainly they lead to relaxation of every other visceral smooth muscle, like your bronchial smooth muscle, your gastrointestinal smooth muscle, your uterine smooth muscle as well. Okay. Inhibition of insulin release can be happening with your verapamil. They're going to inhibit your platelet aggregation as well, but in vitro use है, in vivo में ऐसा कुछ demonstrated नहीं है. So what are the different drugs we have? We have verapamil. Verapamil जो हमारा first है. Verapamil it dilates the arteriole, इसके कारण जो मेरा total peripheral resistance that's going to go up. First thing, BP is only modestly lowered. हार्ट रेट और एबी कंडक्शन मेरा डेफिनेटली इज गोइंग टू गेट डिप्रेस, एंड कार्डियक आउटपुट को क्या होगा, मेनली इट्स गोइंग टू बी नॉर्मल. व्हाई? बिकॉज मेरा जो भी मैंने ब्लड प्रेशर कम किया उसके कारण रिफ्लेक्स सिंपैथेटिक स्टिमुलेशन के कारण, और या फिर एओर्टिक इंपीडेंस भी तो कम हो रही है. आई एम सीइंग टोटल पेरिफेरल रेजिस्टेंस इज आल्सो डिक्रीजिंग, तो आफ्टर लोड इज डिक्रीजिंग, तो कार्डियक आउटपुट माइट बी नॉर्मल. ठीक है, व्हाट आर द डिफरेंट एडवर्स इफेक्ट्स? हमने अभी कहा कि जीआईटी स्मूथ मसल्स को भी रिलैक्स करेगा, तो माइट सी कॉन्स्टिपेशन. ठीक है, अगर इसके कार्डियक डिप्रेसेंट इफेक्ट्स हैं, आई सी ब्राडिकार्डिया, आई सी नोसिया. ठीक है, एंड व्हाट एल्स, अगर और मेरी क्यूटेनियस ब्लड वेसल्स को अगर ये डायलेट करेगा, विजुअलाइजेशन, आई माइट सी फ्लशिंग. मेनिंजियल को करेगा तो हेडेक मिलेगा. एंकल एडीमा कैन आल्सो ऑकर, बट दिस एंकल एडीमा इज मोर कॉमन इन डीएचपीज एज कंपेयर्ड टू योर verapamil. ठीक है, a very important thing is contraindication. देखो इसकी second and third degree heart block. Why? Because it's already blocking the AV node. तो AV node को अगर ये further block कर देगा, मतलब मान लो किसी को second degree heart block है, and you give him CCB on top, AV node block कर देगा further वो, and that will lead to progression of your second degree heart block to your third degree heart block. ठीक है, so that is the reason why they're contraindicated in your second degree and third degree heart block. A very important thing, they can precipitate CHF in patients with pre-existing heart disease because they can decompensate the heart. ठीक है, and a very important thing, do not give them with beta blockers. Why? Because beta blockers also need to AV nodal delay, and CCB also need to AV nodal delay. दोनों का potentiation ना हो जाए, and the patient might end up in heart block. इस करके भी avoid their combination. Diltiazem क्या है? It's a less potent vasodilator when compared to nifedipine or verapamil. I told you vasodilation maximized with DHPs, followed by verapamil, followed by diltiazem. Okay? Cardiac action is mainly with your verapamil, followed by diltiazem, followed by DHPs. Okay? So it's going to have a modest direct negative inotropic effect, and it's going to dilate the coronaries. Adverse effects इसके guys बिल्कुल similar है. ठीक है? Let's see further. Now हमारे last हैं DHPs. अब DHPs हमारे पास जो पहले ड्रग था, that was nifedipine. problem with nifedipine, and we saw with the trials as well, जो हमारे slower long acting DHPs है ना, they are preferred. Why? Because they have less amount of reflex sympathetic stimulation and milder side effects. क्यों? Whenever I'm going to give a short acting drug, rapidly BP को कम करेगा और उसके कारण मेरे को rapidly reflex sympathetic stimulation मिलेगा, और मैं अंजाइना के लिए दे रहा था, बट आई हैव कॉज द पेशेंट टैकिकार्डिया, और उसके कारण फर्दर डायस्टोलिक फिलिंग मेरी कम हो जाएगी और मेरा ऑक्सीजन डिमांड बढ़ जाएगा. इस करके नाउ वी प्रेफर स्लोअर एक्टिंग, लॉन्ग एक्टिंग, स्लो एक्टिंग DHPs. So nifedipine has gone out of favor in case of your angina. So nifedipine जो मेरा प्रोटोटाइप ड्रग था, इट वाज अ रैपिडली एक्टिंग ड्रग, शॉर्ट एक्टिंग ड्रग, तो अब मैं वो ये नहीं यूज करता. amlodipine however, इसके जो peak levels है they're achieved out to 6 to 9 hours, so it's relatively slower acting drug. Then we have other drugs as well, CCP DHPs में we have philodipine. Nitrindipine, guys, I've already talked to you कि थोड़ा सा novel drug है because it also decreases nitric oxide. Nitrindipine and nitro आ रहा है word, so it's going to increase your levels of nitric oxide, and we know nitric oxide can further your lead to vasodilation, and also it inhibits atherogenesis by having a mild anti-aggregatory effect as well. Then you have other drugs. We have lacidipine, we have cilnidipine. ठीक है, cilnidipine की बस बात ये है, it's going to block your L type of calcium channels as well and N type of calcium channels as well. So it has been seen because neurons में present होते हैं N type of calcium channels, so it might decrease your adrenergic reflex sympathetic stimulation. इसके कारण cilnidipine do not have reflex tachycardia that was associated with other DHPs. Then we have nimodipine. Nimodipine की बात simple ये है, it has higher blood-brain barrier penetration की capacity, and hence I'm going to use it for some conditions जिसमें मेरे cerebral blood vessels are getting involved. And what is that? Mainly, guys, subarachnoid hemorrhage. Subarachnoid hemorrhage में it has been seen 4 to 7 days after the subarachnoid hemorrhage, what happens is जो मेरे cerebral blood vessels हैं they're going to undergo vasoconstriction, and उसके कारण I get a delayed ischemic neurological deficit. ठीक है, DIND, delayed ischemic neurological deficit. उसे प्रिवेंट करने के लिए बाय पेनिट्रेटिंग द ब्लड ब्रेन बैरियर माय निमोडिपिन इज गोइंग टू डू वंडर्स. ठीक है, देन निकार्डिपिन है, इट्स अ वेजो सेलेक्टिव ड्रग, शॉर्ट एक्टिंग ड्रग है व्हिच वी कैन यूज इन हाइपरटेंसिव इमरजेंसीज. ठीक है, हमने फार्माकोकाइनेटिक्स के बारे में ऑलरेडी पढ़ लिया गाइस. जस्ट रिमेंबर वन मोर थिंग, मिनिमम प्रोटीन बाउंड ड्रग इज विद डिल्टिazine एंड द मैक्सिमम प्रोटीन बाउंड ड्रग इज विद योर फिलोडिपिन. हमने ऑलरेडी बायो ट्रांसफॉर्मेशन के बारे में पढ़ा है. जस्ट रिमेंबर वन मोर थिंग गाइस, वेरापिमिल इनहिबिट्स इट्स ओन मेटाबॉलिज्म, मतलब उसका टीहा फर्दर क्रॉनिक डोजेस पे इट्स गोइंग टू इंक्रीज फर्दर. ठीक है, राइट. एडवर्स इफेक्ट्स हमने ऑलरेडी सारे पढ़ लिए हैं, बट जस्ट रिमेंबर गाइस, पेरिफेरल एडीमा इज मोर विद DHPs, फ्लशिंग वाज मोर विद DHPs, nausea however is more with verapamil. ठीक है, we can see profound hypertension, we can see reflex sympathetic stimulation, that is tachycardia and palpitations, mainly with DHPs again. बट इसमें हमारा cilnidipine was very novel because वो N type of voltage gated calcium channels को भी inhibit कर रहा था. I could see AV block, bradycardia, arrhythmias as well, mainly with your cardiac drugs, that is verapamil and diltiazem. ठीक है, so this is what's happening. Constipation हो रहा था, again it could happen with DHPs, and just remember gingival hyperplasia verapamil में दिख सकता है, and nausea even आपको verapamil में दिख सकता है. So these are the contraindications, guys. इसमें I just wanted to remember this one: SA node and AV nodal block, sick sinus syndrome, and very importantly WBW syndrome. हमने ऑलरेडी डिस्कस किया हुआ है, why is it contraindicated in WBW syndrome. ठीक है, राइट. So let's move forwards. इसके uses क्या है CCBs के? We can use it in angina, and they're the drug of choice in what? They're the drug of choice in variant angina, because variant angina में मेरी instable मेरी coronary vascular tone थी, उसके कारण I was having severe vasoconstriction that would lead to transmural ischemia. By blocking those smooth muscle cells, I'm going to see relief. ठीक है, right. One more indication is your unstable angina, myocardial infarction में. Now we see, we already know जो calcium है ना, ये बहुत problematic है, because this calcium actually when it comes inside the cytosol from outside, whenever membrane damage occurs ना, cytosol में जो calcium है वो accumulate होने लग जाता है from the extracellular fluid. Now this calcium comes inside into the cytosol. What happens is this calcium is going to open a channel in your mitochondria that's known as the mitochondrial transient permeability pore, MTPP कहते हैं इसे, और इसके through we are going to have release of this cytochrome C, and the cytochrome C is going to activate your intrinsic pathway of your apoptosis, और उसके कारण myocardial ischemia और cellular damage further exacerbate होता है. By blocking these CCB, by blocking these calcium channels, इसके कारण it has been seen that it reduces the rate of your reinfarction and death in patients. ठीक है, but without heart failure however. Heart failure अगर already है तो CCBs further cardiac contractility को कम कर सकते हैं. Cardiac arrhythmias में guys PSVT, paroxysmal supraventricular tachycardia में it has been used as a second line drug. ठीक है, mainly we give adenosine in those cases, 6 milligram IV saline chase, but हम ये भी दे सकते हैं, that is CCBs can also be given. Therapeutic uses HOCM. ठीक है, HOCM में it can be given. ठीक है, HOCM में that is hypertrophic obstructive cardiomyopathy में it might be given. हमने SCH की already बात की थी guys कि how this was the nicardipine could be used. Raynaud's phenomena में they're also the drug of choice because they relieve the peripheral vasospasm that occurs in your Raynaud's phenomena. They can be given for prophylaxis of your migraine as well. ठीक है, so ये हमारे सारे drugs हो गए. हमने ऑलरेडी एंड दीज आर द इंटरेक्शंस गाइस. हमने कहा था सिल्डेनाफिर को नाइट्रेट के साथ कभी कंबाइन नहीं करना है, बीटा ब्लॉकर्स को सीसीबीज के साथ कभी कंबाइन नहीं करना है बिकॉज इट मे लीड टू फर्दर एवी नोडल ब्लॉकेज. सो ये नहीं करना है हमें. ठीक है, एंड जस्ट सी गाइस सीसीबीज जो है कैल्शियम चैनल ब्लॉकर जो है एंड डाइजॉक्सिन का गाइस देखना जो मेन इंटरेक्शन है कि CCBs when given with digoxin they increase the plasma levels of your digoxin, so that might precipitate your digoxin toxicity. ठीक है, कॉम्बिनेशन थेरेपी में क्या अच्छा है, we can give nitrates plus beta blockers. ठीक है, why nitrates क्या कर रहे थे, they were decreasing the preload, that's good, they were decreasing the oxygen demand, that's great. प्रॉब्लम क्या थी, because they will lead to reflex sympathetic stimulation, है ना. Reflex sympathetic stimulation was a problem. Don't worry, now we give beta blockers. So reflex sympathetic stimulation को हमने और inhibit कर दिया by giving beta blockers. So it's a very good match made in heaven, nitrate plus beta blockers. Then we can give nitrates plus CCBs as well. क्यों? Because CCBs मेरे afterload कम करेंगे and मेरे nitrate preload कम करेंगे. That's good. And some आजकल usually क्या कर रहे हैं, the people are even combining your beta blockers and CCBs and nitrate, but just remember they have to be DHP and they have to be slow acting. वरना अगर मैं नॉन DHP वाले ब्रैपमिल या डिल्टियाज्म को कंबाइन कर दूं बीटा ब्लॉकर के साथ, तो दैट इज नॉट अ गुड कॉम्बिनेशन, दैट कैन लीड टू एवी नोडल ब्लॉकेज. सो दीज आर द डिफरेंट रैशनल ऑफ योर कॉम्बिनेशन थेरेपी इन योर एंजाइना. ठीक है, नाउ सम अदर जो नोबल मेरे एंटी एंजाइनल ड्रग है, वन ऑफ देम इज निकोरांडिल गाइस. सो व्हाट इज दिस निकोरांडिल इज, इट्स गोइंग टू एक्टिवेट दिस पोटेशियम चैनल, दैट इज ATP सेंसिटिव पोटेशियम चैनल. ठीक है, उसके कारण एक चीज जो होगी दैट्स गोइंग टू बी आर्टेरियो डायलेटेशन, मतलब आफ्टर लोड ये कम कर सकता है. And nicorandil is also going to be serve as a nitric oxide donor, so that's going to lead to venodilation as well. एक तो इसका ये action हो गया. ठीक है, what else? So it decreases the preload by leading to venodilation, and it decreases the afterload by leading to arteriodilation. Coronary flow is increased, and there is no effect on your cardiac contractility, so that's a very good drug. Done. Even what makes it even better is it's going to lead to something known as ischemic preconditioning. So what is this, guys? Ischemic preconditioning का मतलब ये है कि brief period of ischemia, ठीक है, are going to be protective when you use this drug against a further final ischemic result. और ये क्यों हो रहा है पता है गाइस, मेनली इट इज अकरिंग जो ये इस्कीमिया रिपोलराइजेशन के कारण जो फर्दर डैमेज मिलता है ना मुझे, व्हाई इज दैट हैपनिंग, यू नो, इट्स मेनली ड्यू टू कैल्शियम ओवरलोड के कारण. So what does this novel drug do is by stimulating your ATP sensitive potassium channels, it's going to hyperpolarize the membrane of your myocyte. और उससे क्या होगा, कैल्शियम कम अंदर जाएगा इनटू द साइटोसॉल, एंड अगर कैल्शियम कम अंदर जाएगा, सो दिस चैनल दैट व्हिच आई टोल्ड यू गाइस, माइटोकॉन्ड्रियल परमेबिलिटी ट्रांजिशन पोर, ये कम ओपन होएगा और कम साइटोक्रोम C रिलीज होएगा और कम एपोप्टोसिस होएगा. सो दैट गाइस इज नोन एज योर इस्कीमिक प्रीकंडीशनिंग. मतलब ब्रीफ पीरियड ऑफ इस्कीमिया हुआ, व्हाट शुड हैव हैपेंड, आई शुड हैव सीन रीपरफ्यूजन इंजरी. अब मुझे रीपरफ्यूजन इंजरी क्यों नहीं मिल रही है न्यूकोरैंडल से, बिकॉज इट लीड्स टू दिस इस्कीमिक प्रीकंडीशनिंग. How does it do that? By opening these potassium channels that lead to hyperpolarization of the cardiac myocyte. उसके कारण मेरा calcium overload is prevented. उसके कारण मेरा intrinsic pathway of apoptosis is less stimulated. So that makes sense. ठीक है? Just like any other arteriodilatator, it's going to lead to flushing, palpitations, weakness, headache. ये तो होएगा ही. One specific side effect of a nicorandil is aphthous ulcers on the mouth. Right. So the next drug that I have for you is dipyridamole. Dipyridamole का हमने already थोड़ा सा discussion किया था. Dipyridamole, what does it do? Mechanism of action क्या है? Adenosine का, it prevents the reuptake of adenosine and it prevents the degradation of adenosine. तो twofold action है इसका. Now I told you guys, adenosine plays a very important role in autoregulation of your coronary blood flow. मतलब यहाँ पे अगर adenosine को ये इतना ज़्यादा effect कर रहा है, what can happen is ischemic वाले तो effect होंगे ही होंगे. The non-ischemic zones are going to lead to dilatation of their blood vessels, and क्या होएगा guys, auto regulation disturb हो सकती है. So what does it do? It dilates the resistance vessels guys, not the conductance vessels. And what does it do? Abolishes auto regulation. So what is going to happen? See guys, so whenever I'm going to see a plaque over here, यहाँ पे क्या हो रहा है, यहाँ पे मेरे इस्कीमिक मायोकार्डियम है, इट रिलीजेस एडेनोसिन, एंड इसके कारण जो मेरे रेजिस्टेंस वेसल्स है वो वेसोडाइलेटेशन अंडरगो करते हैं एंड वो खुल जाते हैं, सो दैट सम अमाउंट ऑफ ब्लड फ्लो कैन गो इनसाइड. सो दिस इज द प्रोटेक्टिव मैकेनिज्म ऑफ योर ऑटो रेगुलेशन. What can happen if I give dipyridamole is, मेरा जो नॉन इस्कीमिक मायोकार्डियम है उसमें ये एडेनोसिन अगर इंक्रीज हो गया, that can lead to dilatation of these resistance vessels, that can lead to dilatation of these resistance vessels. blood कहाँ जाएगा? blood obviously will go into the non ischemic zones because conducting वाला तो ये blocked है ना. या तो मैं इस conducting वाले को खोल देता, that would have been better, बट अभी मैं रेजिस्टेंस वेसल्स पे वर्क कर रहा हूँ, और रेजिस्टेंस वेसल ने क्या किया, मेरी नॉन इस्केमिक पोर्शन ऑफ द मायोकार्डियम वाली रेजिस्टेंस वेसल हैव आल्सो अंडरगोन वेसोडाइलेशन. सारा का सारा ब्लड फ्लो इज गोइंग टू द नॉन इस्केमिक जोन. इस्केमिक जोन्स आर गोइंग टू सफर. दैट इज द मेन मैकेनिज्म ऑफ योर कोरोनरी स्टील. मतलब मेरे नॉन इस्केमिक मायोकार्डियम is stealing blood from the ischemic myocardium due to this drug that is dipyridamole. ठीक है, so coronary steal phenomena is very predominant in case of your dipyridamole. ठीक है, because it increases your cyclic AMP in your platelets and your PGI2 due to adenosine का reuptake और degradation को prevent करके I might even see an anti-platelet action of dipyridamole, और इसी करके मैं इसे यूज करता. I don't use it in angina per se. I'm going to use it as an anti-platelet drug. ठीक है, along with your clopidogrel and your aspirin. ठीक है, right. Some other drugs we have the ivabradine. Ivabradine हमने already CHF में पढ़ लिया. It's mainly it inhibits the funny channels which are present over there. तो it's what is it? It's a bradycardic drug. मतलब heart rate ये कम करेगा और contractility को ये हाथ भी नहीं लगाएगा, contractility को normal रखेगा. Contractility is normal, heart rate preferentially decreases. So that is the action of your ivabradine. तो अगर heart rate अगर कम होएगा, diastole का prolongation होएगा, उसके कारण हमें see increased amount of perfusion. Then I have other drug that is trimetazidine. So guys, see, this is the pathway that I have for your beta oxidation. So beta oxidation, if you see, so acyl-CoA gets converted to your trans-2-enoyl-CoA via this enzyme that is acyl-CoA dehydrogenase. This trans-2-enoyl-CoA gets converted to 3-hydroxyacyl-CoA, ultimately to 3-keto-acyl-CoA. यहाँ पे मेरा action है. This 3-keto-acyl-CoA, okay, gets converted to acyl-CoA via this enzyme which is known as a thiolase. Okay, so ये beta oxidation का pathway है. What I'm going to do is I'm going to block this fatty acid oxidation. ठीक है, तो फैटी एसिड ऑक्सीडेशन के पाथवे को इनहिबिट करने वाले को ड्रग को क्या कहूंगा मैं, आई एम गोइंग टू कॉल इट एज अ पीफॉक्स इनहिबिटर. दैट इज पाथवे ऑफ योर फैटी एसिड ऑक्सीडेशन को ब्लॉक करना. हाउ डज इट डू दैट? बाय ब्लॉकिंग दिस इंपॉर्टेंट स्टेप, दैट इज योर थायोलेज. सो व्हाट डज इट इनहिबिट? It's going to inhibit long chain 3-keto-acyl CoA thiolase. So this is the drug which inhibits this. इसके कारण क्या होएगा? फैटी एसिड ऑक्सीडेशन कम होएगा, and we know fat requires more amount of oxygen for their utilization, and glucose कम करता है. तो इसके कारण ट्राइमेटाजिडीन के कारण फैटी एसिड ऑक्सीडेशन मेरा कम होएगा, एंड इसके कारण प्रेफरेंशियल ग्लूकोज ऑक्सीडेशन या ग्लूकोज यूटिलाइजेशन मेरा ज्यादा होएगा, एंड हेंस माय ऑक्सीजन डिमांड इज गोइंग टू गो डाउन. सो दैट इज अ नॉर्मल ड्रग, दैट इज ट्राइमेटाजिडीन. ठीक है, व्हाट एल्स? वी हैव ranolazine as well. So ranolazine का मैकेनिज्म ये है, इट इनहिबिट्स द लेट सोडियम चैनल, लेट सोडियम करंट. और हमें ये पता है ये जो लेट सोडियम करंट है, it is responsible for your calcium overload through inhibition of your NCX. So this ranolazine is very important as well. So this is all about your anti-anginal drugs, guys. So let's move forwards with your anti-arrhythmic drugs now. Okay. So what are the different types of arrhythmia and how can I develop it? Okay. So what is an arrhythmia? First of all, arrhythmia is कि मेरी जो normal cardiac rhythm है उससे any deviation from my normal cardiac rhythm, that's known as arrhythmia. Just remember guys, normal आपका maximum heart rate that can be achieved, उसके ऊपर अगर जाए heart rate, that's known as arrhythmia. That is your 220 minus your age. ठीक है, सो अगर मोर देन मैक्सिमम अगर हार्ट रेट अगर आपका जाता है, दैट कुड बी इंडिकेटिव फॉर एरिथमिया. ठीक है, ऑलराइट गाइस. सो व्हाट आर द मैकेनिज्म्स? फर्स्ट थिंग इज इंक्रीज ऑटोमेटिसिटी. जो मेरे ऑटोमेटिक सेल्स हैं विच आर एबल टू अंडरगो योर स्लो डायस्टोलिक एक्शन पोटेंशियल, जो हम कह रहे थे स्लो एक्शन पोटेंशियल जो डेवलप कर सकते हैं सेल्स, अगर उनकी ऑटोमेटिसिटी इंक्रीज हो जाए, वेदर इट बी इन द एट्रिया और इट बी द जंक्शन एबी नोड में, या वेदर इट बी इन द वेंट्रिकल, कहीं पे भी, so that is for first mechanism of this is increased automaticity that is happening. Done. And why that वो क्यों हो सकती है? Either due to sympathetic stimulation, because हमें पता है जब sympathetic stimulation होता है, it's going to activate your HCN channels via protein kinase A, और उसके कारण जो मेरा slope है, what is the slope? This is my phase 4 depolarization slope. ठीक है, ये phase 4 depolarization slope और steeper हो जाएगा. I'm going to see much more amount of conduction, much more amount of positive inotropy happening. So cardiac sympathetic stimulation is one cause of your increased automaticity. What are other causes? The other reason for your arrhythmia generation is your triggered automaticity. ठीक है, so what is this triggered automaticity? इसमें दो types हैं, early after depolarization, delayed after depolarization. I'm going to make it very easy for you guys. So see, so ये मेरा normal action potential था, ये मेरा RMP था, this was my phase 1, this was my phase 2, phase 3, this was my phase 0, this was phase 1, 2, and this was your repolarization, that is 3. Done. Early after depolarization तब होती है when I'm going to prolong the action potential का duration. ठीक है, I'm going to prolong the action potential का duration. उसके कारण what happens is, जो मेरे calcium channel है ना guys, they're going to have enough time to recover now. They were getting inactivated over here, है ना. यहाँ पे जब inactivation start हो गया था तभी मेरा repolarization develop हुआ था. अब वो इतना slow action potential हो रहा है कि मेरे calcium channels what do? They're going to recover, or ये जो increased amount of eye calcium that is coming inside current due to calcium, it's going to trigger another amount of action potential. So this is known as early after depolarization. Why is this happening? This is happening in the early parts of a repolarization. ठीक है, early after depolarization मतलब repolarization के early part पे होएगा. Why is it happening? Due to increased action potential duration which can occur due to increased QT interval. ठीक है, so any cause of an increased QT interval can lead to early after depolarization. What about delayed after depolarization? Delayed after depolarization, guys, could occur due to multiple reasons. First is ischemia. So ischemia, I told you, it can lead to depolarization on its own. Catecholamines can lead to depolarization on its own, and digitalis, because it leads to calcium overload. हमने already digitalis में पढ़ा था that it can lead to delayed after depolarization, and that is the reason why digitalis can lead to any kind of arrhythmia. ठीक है, so ये हमारे delayed after depolarization, and this is हमारा early after depolarization. ठीक है, and the last mechanism, guys, is your re-entry. ठीक है, सो दैट इज री एंट्री, ऑल्सो नोन एज सर्कस मूवमेंट्स. ठीक है, तो कौन कौन सी सर्कस मूवमेंट्स हैं और कैसे कैसे हम जनरेट कर सकते हैं. सो जस्ट रिमेंबर गाइस, दिस मान लो एक रिंग ऑफ योर कार्डिक मसल. सो दिस इज अ रिंग ऑफ योर कार्डिक मसल. सो हाउ कैन आई जनरेट समथिंग that is known as a circus movement or your re-entry. So let's see. So first mechanism is I can create an obstacle. मतलब what can happen is मेरा impulse यहाँ पे आया. Usually what would have happened is मेरा impulse इस pathway से जाता, इस pathway से जाता, it would have met in the middle, and what would have happened is it would have dissipated. So this is normal. Now what is happening is मान लो मेरे यहाँ पे कुछ ब्लॉक हो गया. It could be due to ischemia, it could be due to fibrosis. ठीक है, it could be due to fibrosis कि मेरा MI हुआ, उसके कारण जो scar tissue बने, that can function as obstacle. अब impulse यहाँ पे conduct नहीं होगा तो what's going to happen? ये मेरा impulse आया, it's going to conduct here, यहाँ से वो conduct नहीं हुआ because it is transiently blocked है यहाँ पे. The impulse is going to go over here, here, here. ठीक है, तो पूरा wound up करके आएगा. और अब क्या हो गया, जो मेरे transient block था अब वो खुल गया. And now the impulse that was traveling through here, now it can conduct through this as well. So now this is what not should have happened. Usually मेरा ये जो cardiac ring है, ये यहाँ से अगर start होना था impulse, it would have abolished over here. But now what is happening is transient block के कारण, which further gets relieved, I'm going to see this happening. So this is known as a circus movement. ये जो गोल गोल घूम रहे हैं जो cardiac impulse बार बार इस same amount of ring of cardiac muscle से, so that is known as first thing is obstacle. द सेकेंड रीजन जिसके थ्रू मैं कर सकता हूँ, अगर मैं कंडक्शन ही स्लो कर दूँ तो व्हाट कैन हैपन इज जितना टाइम वो लगाएगा, मान लो अगर कंडक्शन यूजुअली क्या होता है, नॉर्मली कंडक्शन इतनी ज्यादा स्लो होती है कि जो ओरिजिनल साइट है ना डिपोलाइजेशन की, दैट इज रिफ्रैक्टरी फॉर फर्दर स्टिमुलस. बट अगर मैंने कंडक्शन को स्लो कर दिया, व्हाट कैन हैपन इज जो मेरी इनिशियल साइट ऑफ डिपोलाइजेशन थी, दैट माइट अंडरगो रिपोलाइजेशन. एंड इफ इट दैट अंडरगोज रिपोलाइजेशन, जो मेरी इंपल्स है वो वापस इसके थ्रू जा सकती है. So the second mechanism by which I can I can permit re-entry is via your conduction का slowing. First is obstacle, second is conduction का slowing, and जो third है that is your pathway becomes longer. कि मेरा heart dilate हो गया, मेरा pathway ही लंबा हो गया, तो conduction velocity even if it remains normal as well, but it's going to take longer amount of time. जो मेरा initial amount of depolarization वाला tissue था, now it becomes no longer refractory and it's going to conduct the impulse again. So that is your third mechanism कि pathway आपको longer हो गया. That mainly happens in your DCM, that is your dilated cardiomyopathy. So now see re-entry. Now different types of re-entry है. We can have AV nodal की re-entry. हमें पता है AV node, we are not going to go into much detail about it. We know कि AV node में दो pathways होते हैं. We have the fast pathway and the slow pathway. ठीक है? And usually AV node ऐसा बना है कि जो fast pathway, it is fast definitely, but it has an increased amount of effective refractive period. मतलब ज़्यादा time लगेगा इसे to repolarize. Whereas the slow pathway, it is slower, but it has a lesser amount of effective refractive period. ठीक है, होएगा क्या guys? It's very simple. Usually whenever the impulse comes over here, जब भी impulse एक इसमें से through जाती है, तो fast pathway के it's going to get relatively very fast conducted into the ventricles. ठीक है, and slow pathway के through it's not going to get conducted, and I see a block over here that is happening. तो ये जो impulse है वापस नहीं जाती है. That makes sense. But sometimes what can happen is मेरा impulse ये ऐसे नोड से नहीं आया. ठीक है, now it is a ectopic. now एक ectopic ने फायर किया और वो ऐसा फायर किया ectopic ने जो मेरा फास्ट पाथवे है ना, because it has an increased amount of effective refractive period, it is still refractory guys. अब वो रिफ्रैक्टरी है तो what can happen is अब मेरा वो फास्ट पाथवे के थ्रू जाएगा ही नहीं, इट्स गोइंग टू गो प्रेफरेंशियली थ्रू द स्लो पाथवे. पहले what was happening is it was getting split up into two pathways. बट यहाँ पे बिकॉज मेरा फास्ट पाथवे हैज अ इंक्रीज अमाउंट इफेक्टिव रिफ्रैक्टिव पीरियड और मेरे एक टॉपिक ने फायर कर दिया है, आई एम नॉट गोइंग टू सी कंडक्शन थ्रू दैट. माय कंडक्शन इज गोइंग टू गो थ्रू द स्लोअर पाथवे एंड इट्स गोइंग टू गो अप, इट्स गोइंग टू गो इनटू द वेंट्रिकल्स कंडक्टेड, दैट्स फाइन. बट प्रॉब्लम कहाँ राइज होगी व्हेन इट्स गोइंग टू रिटर्न बैक. अब ये जो पहले वाला जो डीपोलराइज था ना, बिकॉज इफेक्टिव रिफ्रैक्टिव पीरियड का लंबा था पर कभी तो खत्म होएगा, नाउ इट नो लॉन्गर बिकम्स रिफ्रैक्टरी एंड आई सी अगेन अ सर्कस री एंट्री. So that is another pathway. This can occur either at the level of the AV node. So I'm going to call it as AV nodal reentrant tachycardia, AVNRT. So that's a one type of your supraventricular tachycardia. The another type of a supraventricular tachycardia is, so this is AVNRT, guys. So that is one thing. The another type of a supraventricular tachycardia is, guys, atrioventricular reciprocating tachycardia, AVRT. ये क्यों mediate हो रहा है? Due to the bundle of Kent. And which condition do I see it in? I'm going to see it in WW syndrome. So that is known as AVRT, guys. ठीक है? So ये मेरे दो pathways हैं. They're both leading to supraventricular tachycardia. If someone asks you what is the most common cause of your paroxysmal supraventricular tachycardia or supraventricular tachycardia, it's going to be AV nodal reentrant tachycardia. WW syndrome इतना common नहीं है, ठीक है? Alright, guys. So हमने पढ़ लिया कि हमारा एरिथमिया हो क्यों रहा है जनरेट. Now we are going to discuss mainly on the drugs. Initially I was planning to discuss whole of arrhythmia with you guys as well, but I think वो हम ECG में टेकअप कर सकते हैं. तो आज हम बेसिकली हम ड्रग्स पे फोकस करेंगे. Alright. So let's just see. So the classification of antiarrhythmic drugs goes like this. Okay. So this is the Vaughan, Williams and Singh classification. इसके थ्रू हमने and जो हमारे antiarrhythmics हैं उन्हें 4 classes में derive किया है. Class 1, Class 2, Class 3, Class 4. Class 1 is further divided into 1A, 1B and 1C. तो पहले C, Class 1. Class 1 are going to inhibit your sodium channels. मतलब they're going to have a membrane stabilizing effect. Sodium channel blockers को हम क्या कहते हैं? Membrane stabilizers कहते हैं. Class 1 is membrane stabilizing drugs. जो मेरे Class 2 है, they're going to decrease the rate of your depolarization and basically they are your anti-adrenergic drugs. मतलब basically your beta blockers. ठीक है? जो मेरे Class 3 drug हैं, they're going to inhibit your potassium channels. और मेरे जब potassium channels inhibit होंगे, मतलब potassium channels repolarize के लिए responsible हैं, तो मेरा क्या होगा? Conduction और मेरा action potential का duration increase होएगा. So these Class 3 वाले drugs are those drugs which are going to increase your action potential duration. And last में मेरे आते हैं Class 4 drugs which are going to inhibit your slow type of calcium channels, जिसमें हमने already बात की. DHPs do not affect the heart. The only two drugs which are calcium channel blockers which affect the heart are your verapamil and diltiazem. मेरे होंगे ये हमारी accordingly classes होगी. Class 1 are membrane stabilizers, Class 2 are anti-adrenergic drugs, Class 3 are going to inhibit your potassium channel, increase the action potential duration, and Class 4 drugs are going to inhibit your calcium channels and basically they are verapamil and diltiazem. So ये हमारे antiarrhythmics की class होगी. Now let's talk about Class 1. Alright, so ये हमने ऑलरेडी बात की है गाइस कि हमारे जो सोडियम चैनल होता है इसका स्ट्रक्चर है, तो गोइंग टू हैव समथिंग नोन एज द एक्टिवेशन गेट एंड या समथिंग नोन एज द इनएक्टिवेशन गेट. ठीक है? एट रेस्ट एट आरएमपी क्या होता है? दिस इनएक्टिवेशन गेट इज ओपन, एक्टिवेशन गेट इज क्लोज. ठीक है? व्हेन इट गेट्स डीपोलराइज्ड बोथ ऑफ देम गेट ओपन. मतलब एक्टिवेशन गेट भी ओपन है, इनएक्टिवेशन गेट भी ओपन है. एंड व्हेन आई गोइंग टू कॉल द चैनल इज इनएक्टिवेटेड, मतलब फर्दर डीपोलराइजेशन से मेरे क्या होते हैं? सोडियम चैनल्स इनएक्टिवेट होने लग जाते हैं. तो क्या होता है? मेनली माय एच गेट क्लोजेस. So you see, H gate is closed over here, but the मेरा ये जो मेरा M gate है, that is activation gate is still open. So you see, at RMP, my inactivation gate is open, activation gate is closed. At open state, both of them are open. Whereas in inactivated state, my inactivation gate or H gate is closed. ठीक है? Now let's see, guys. So ये मेरा resting state है, ये मेरा activated state है, ये मेरा inactivated state है. When the cell undergoes repolarization, guys, what I'm going to see is मेरे inactivated channels जो है ना, they're going to get back converted into a resting state, जिसमें क्या है? एक्टिवेशन गेट मेरे क्लोज है, इनएक्टिवेशन गेट मेरे ओपन है. ठीक है? सो ये इस प्रोसेस को क्या कहते हैं? गोइंग टू कॉल इट एज अ रिकवरी प्रोसेस. ठीक है? रिकवरी. नाउ इंपॉर्टेंट थिंग टू रिमेंबर गाइस, जो हमारे क्लास 1 ड्रग्स हैं दे आर ऑफ 3 टाइप्स, 1A, 1B, 1C. ठीक है गाइस? जो मेरे 1B ड्रग्स हैं गाइस, दे गोइंग टू बाइंड टू द सोडियम चैनल इन इट्स इनएक्टिवेटेड स्टेट, whereas जो मेरे 1A and 1C drugs हैं, they're going to bind to the channel in its open state. Very important thing. 1A and 1C मतलब जो polar हैं drugs, 1A बीच में B है उसे छोड़ो, 1A and 1C are going to bind to its open state uninhibited, whereas 1B are going to bind to its inactivated or closed state and going to inhibit it. That makes sense? ठीक है? So class 1 basically they bind easily to the activated and or the inactivated state. But did I mention resting state पे कोई सोडियम चैनल ब्लॉकर ने वर्क नहीं किया. So this is a characteristic thing. ठीक है? So MCQs यहाँ से भी आ सकते हैं. Where which state do they bind to actually? Resting state पे sodium channels are not going to block the resting state. ठीक है? So class 1 are going to bind easily to the activated and or the inactivated state of sodium channels, but poorly to the resting state. And just remember guys, they're going to block more amount of channels when activation and inactivation fast है. ठीक है? मतलब जब रैपिडली मेरे फायरिंग फाइबर्स है ना, जो मेरे एक्टॉपिक फाइबर्स हैं, when they are more firing, matlab increased amount of activation and inactivation is happening, more amount of sodium channels are not in the recovery, not in the RMP, but they're either activated or inactivated. तो इसके कारण maximum amount मुझे कब मिलेगा, जब it's going to act, it's going to work on those fibers which are rapidly depolarizing, and that is known as a use dependent blockade. मतलब जितने ज्यादा आप यूज करोगे ना अपने फाइबर्स को, वही ये जो ड्रग है उन्हीं को स्पेसिफिकली ब्लॉक करता है. दैट इज नोन एज यूज डिपेंडेंट ब्लॉकेड. एंड जस्ट वन मोर थिंग गाइस, they're going to block partially depolarized fibers more. What do I mean by that? Partial depolarization क्यों हो सकता है? Mainly मेरा arrhythmia अगर हो रहा है, that can occur due to sympathetic stimulation. That sympathetic stimulation can lead to partial depolarization. That arrhythmia can occur due to ischemia, and I told you ischemia can lead to partial depolarization. Why is this so advantageous to us is, अगर partial depolarization में क्या होता है ना guys, जैसे जैसे मेरा RMP becomes more positive, RMP में I'm going to see a negative decrease, so as to say, what happens is more sodium channels are going to get inactivated. And if more sodium channels are going to get inactivated, my antiarrhythmic drugs are binding where? Are binding either to the activated state or inactivated state. To inactivated अगर मेरे increase कर गए हैं और resting मेरे कम हो गए हैं, then I'm going to see further action. मतलब अगर मेरा rate of depolarization increase होता है, मेरे class 1 जो मेरे drugs हैं, they can more block them. That is known as use dependent blockade. And second use dependent blockade क्या है? अगर मेरे partially depolarized fibers हैं, because इनमें inactivation gates ज्यादा हैं, class 1 drugs are going to work more effectively towards them. So this is class 1. ठीक है, यही वो diagrammatically depicted है guys, so I can see. Alright guys, so these are the drugs. We have class 1A, 1B and 1C. So पहले एक बार just overview देख लेते हैं. class 1C, class 1A जो है ना guys, they're going to have the maximum delay in depolarization. ठीक है. 1B, because they are what, they lead to potassium channel opening, इसमें action potential duration actually decrease हो सकती है 1B में. And 1C में क्या होता है, they have the maximum sodium blockade. मतलब if you see phase 0 सबसे ज्यादा स्लो किसमें, सबसे ज्यादा स्लोप कम किसका है, 1C का है, because they have the maximum amount of sodium channel blockade. That's first MCQ. The second MCQ is action potential duration prolonged maximum किसमें है, it's mainly class 1A drugs. And third MCQ, action potential duration किसमें कम हो सकती है, that is 1B drugs. That makes sense. Alright, ठीक है. So let's see एक एक करके. Class 1A drugs, इसमें we have different types. We have procainamide, we have diisopyramide, and we have quinidine. Quinidine we don't use, तो ज़्यादा नहीं पढ़ेंगे हम basically. So first one is procainamide. So what is it going to do? It's going to slow the uptake of your action potential, मतलब phase 0 की slope कम करेगा, हमने अभी देखा. And I told you guys, it's going to increase your action potential duration. Can you see it? Action potential duration increase होगी, पहले इतनी थी, अब increase होगी. क्यों increase हुई? Because these drugs lead to potassium channel blockade. They lead to potassium channel blockade. They're going to decrease the conduction, very good, and they're going to increase the QRS duration. They're going to have a weaker depressant activity of your cardiac contractility as well as AV nodal conduction. This is where I'm talking about your procainamide. That makes sense. What about your side effects of your procainamide? Side effect क्या है mainly? Because action potential duration increase हो रहा है, that can lead to increase in QT interval, and whenever my QT interval is going to occur, which arrhythmia can I predispose the patient to? I can develop Torsades-de-Pons. Okay, so Torsades-de-Pons can develop in these patients. So that is Torsades-de-Pons, also known as polymorphic ventricular tachycardia. Okay, polymorphic मतलब it's going to be changing. ऐसे. It's going to change. That's your polymorphic ventricular tachycardia. What else? I can develop arthralgia and arthritis. That's a lupus erythematous type of reaction. Procainamide can lead to angioedema. If you remember SLE वाले drugs, I think HIP आता है उसमें. You might be remembering hydralazine and your isoniazid procainamide. तो इसके थ्रू arthralgia, arthritis can occur, and your lupus SLE like reaction can occur, angioedema can occur, hepatitis, agranulocytosis has also been reported. ठीक है. Use क्या mainly guys? Procainamide is a very important drug in your VT. That is a monomorphic ventricular tachycardia and every supraventricular tachycardia. Why guys? Because it blocks the AV node. I told you, because it decreases the conduction, it's going to block the AV node, and hence I can use these drugs in a supraventricular tachycardia, whether it be AVRT or whether it be your AVNRT. इनमें मैं use कर सकते हैं. They are not the preferential drugs. Supraventricular tachycardia या PSVT में mainly because adenosine, but we can try these drugs as well because they decrease the AV nodal conduction. Why we're so concerned about the supraventricular tachycardia is we need to decrease the AV nodal conduction कि वो AV arrhythmia मेरा atrial arrhythmia ventricular arrhythmia ना बन जाए, which is more fatal. ठीक है, that makes sense. Quinidine, we know it's a dextroisomer of your antimalarial, that is your quinine. बस one thing that I want to remember for your quinidine is बहुत ज़्यादा QT interval को prolong करता है. It has modest anti-muscarinic action, मतलब इसके सारे जो side effects हैं, you're going to have atropine वाले side effects, and it's going to, the patient might also develop synchronism, that is headache, dizziness, tinnitus can occur. ठीक है, तो इसकी alpha blocking activity के कारण इसमें hypotension हो सकता है इन patients में, muscarinic blockade के कारण atropine like side effects हो सकते हैं, these patient can develop synchronism, and we know ये action potential duration को तो increase करता ही है, QT interval को increase करता ही है, so it might lead to your Torsades response as well. तो ये हमने सारा देख लिया, right? So these are the extra cardiac side effects. ये इसके हैं. Mainly I want you to remember tinnitus, vertigo, deafness, visual disturbances, and mental changes can occur. That is known as synchronism. Okay. SE we have diisopyramide, so nothing special about it, but just remember strongest antimuscarinic action diisopyramide का मतलब it is diisopyramide followed by quinidine followed by procainamide. Procainamide has no antimuscarinic action. Strongest is for your diisopyramide. Similar risk of Torsades response as compared to other drugs, and again you can use it in your ventricular arrhythmias as well. ठीक है, ये हमारे हो गए 1A drugs. Now the next amount of drugs are your 1B drugs. ठीक है, 1B drugs क्या है, हमने already बात की. 1B drugs are going to block channel more in the inactivated state, less in the activated state. हमने already बात की. Open कौन block करे थे, mainly your 1A and 1C. And inactivated state में कौन block करे थे, mainly your 1B. ठीक है, so they're going to block channels more in the inactivated state first. ठीक है, they do not prolong the action potential duration, whereas it has been seen 1B वाले drug they might even abbreviate your action potential का duration, मतलब कम भी कर सकते हैं. ठीक है, so the first one, which is the most important one, that is your lidocaine. Lidocaine, remember guys, सबसे ज़्यादा least cardiotoxic sodium channel blocker है, मतलब it has no pro-arrhythmic potential. That is the first thing that I want you to remember. ठीक है, just remember guys, it enhances phase 4 depolarization and मतलब enhance जो हुई है phase 4 depolarization and partially depolarized fibers और stretch Purkinje fibers are antagonized. Very super duper important guys. SA nodal automaticity is not depressed. SA node की automaticity is not depressed. मतलब atrial muscles पे कोई effect नहीं पड़ा है, SA node पे कोई effect नहीं पड़ा है. So guys, it's very logical. Can I use lidocaine in a supraventricular tachycardia? I can't. Supraventricular tachyarrhythmias में lidocaine is not that important. Mainly it is important for your ventricular fibrillation में, when we जो मेरे ventricular arrhythmias में उसमें मैं use कर सकता हूँ lidocaine. That's very good drug. But supraventricular tachycardia में it can't be used because it does not affect your SA node की automaticity or your atrial muscle fibers की automaticity. So it's an important thing. Atrial re-entry is also not affected. ठीक है, very important. तो ये भी नहीं affect हो सकती, but it can suppress re-entry in ventricular arrhythmias. इस करके इसका main जो indication है that's your ventricular arrhythmias only. ठीक है, we know it's going to block in the inactivated state. हमने already बात की. And just remember guys, mainly इसके adverse effects क्या हैं, paresthesias हैं. We're talking about lidocaine. Paresthesia obviously क्या है ना, सोडियम चैनल ब्लॉकर है, लोकल एनेस्थेटिक है, तो paresthesia, nystagmus, tremor, nausea and drowsiness. So these are the effects of your lidocaine. Uses, have I mentioned anywhere that is your supraventricular tachycardia? I haven't. Mainly it is used in VT, or it can be used in prevention of ventricular fibrillation. And the main जो चीज है, that is your digitalis induced ventricular tachycardia. ठीक है, very important thing. Why am I not using 1A drugs in case of digitalis induced tachycardia? Is, as you know guys, digitalis क्या है, उसका वेगल इफेक्ट के कारण I might see AV blockade. तो अगर मैंने 1A वाला ड्रग दे दिया which leads to AV blockade, दोनों का synergize नहीं हो जाएगा इफेक्ट. So I need something that can actually decrease the AV nodal blockade so that AV node block ना हो जाए, hard block ना हो जाए. इस करके I might give something which doesn't affect the action potential duration of my AV node. ठीक है, and the best drug is lidocaine. So digitalis induced VT and your VT में I can use lidocaine. ठीक है, then I have other drug that is mexiletine. बस बात ये रखनी है guys, lidocaine it doesn't have an oral preparation, so it's inactive orally. It only is given IV or local, obviously local में as a local anesthetic. But mexiletine was developed as a oral derivative of your lidocaine. Same side effects, सब कुछ same है. ठीक है, and mexiletine has been preferred for your post-MI ventricular arrhythmias. ठीक है, but oral use, however, because we still have mexiletine as oral, but we still don't give it orally. ठीक है, questionable benefit है in case of VT. ठीक है, mainly still use IV only. Then we have 1A हो गया, 1B हो गया, 1C पे आते हैं. 1C are the most arrhythmogenic drugs. Maximum sodium channel blockade है, they are the longest recovery time. ठीक है, and they broaden the QRS. इसमें कौन कौन से drugs हैं? We have propafenone. ठीक है, propafenone है. So mainly propafenone की एक problem है, it can block the beta channels. तो beta channels को block करने के कारण it might precipitate CHF and bronchospasm. So it's not used in patients with your ischemic heart disease or asthmatic patients. So this is an important thing. ठीक है, and propafenone में क्यों use कर सकता हूँ? I can use it in maintaining sinus rhythm in your paroxysmal or atrial fibrillation. Mainly atrial fibrillation में I can use propafenone. I can use it for prophylaxis of your PSVT, that is AVRT or AVNRT, or I can even use it in your atrial fibrillation used with CCBs. The next drug that I have for you is again flecainide. Flecainide का एक important thing, it doesn't have any beta blocking property as was seen in propafenone. ठीक है, ठीक है. Now हमारे क्लास 2 में क्या है? एंटी एड्रेनर्जिक ड्रग्स, मतलब बेसिकली दे आर योर बीटा ब्लॉकर्स. एंटी एड्रेनर्जिक ड्रग्स में हमारे आगे बीटा ब्लॉकर्स. सो फर्स्ट ऑफ ऑल आई हैव योर प्रोप्रानोलॉल. ठीक है, propranolol क्या करता है, it decreases your phase 4 depolarization drug, that is a slow action potential की जो slope है वो सब में कम करेगा, especially in your SA node, Purkinje fibers and other ectopics सब में, whenever they are increased under adrenergic influence. But the adrenergic influence में it's going to work much more. ठीक है, that's the first thing. Because it increases the effective refractory period of AV node, it can lead to AV nodal blockade. As you have seen, beta blockers we don't combine with your CCBs. Okay? But remember, there is no paradoxical tachycardia. Okay? And it abolishes re-entrant tachyarrhythmia. It increases the PR interval. Okay? And mainly use मैं किसमें करूँगा? Propranolol is inappropriate sinus tachycardia. That's one. Second is PSVT. But obviously, PSVT is less effective than the drug of choice, that is your adenosine. But I can use that because it can lead to AV nodal blockade. It can be used in rate control in atrial fibrillation as well as atrial flutter. Again, the main mechanism is AV nodal blockade. I can use it in pheochromocytoma when it leads to arrhythmia. I can use this as in case of when I told you guys halothane. Halothane can lead to what? It can lead to arrhythmias. It can adrenergically mediated. It sensitizes the heart to the arrhythmogenic potential of your adrenaline. So we have studied this statement. So उस case में I can use your beta blockers, especially anesthesia के कारण halothane मैंने given general anesthetic के कारण. And I can also use beta blockers in case of your Torsades response. ठीक है? Esmolol है. Esmolol का main action is emergency control अगर मुझे चाहिए in case of your atrial flutter and atrial fibrillation, I can use esmolol. बहुत quick acting drug है. I can again use it in your PSVT. So beta blockers and your हमारे done हो गए. Then class 3 drugs हैं. Class 3 drugs में एक important thing, they increase the action potential duration. हमने already कहा because they block the potassium channels. So they're going to block the potassium channels, जिसके कारण increase in action potential duration होगा. Now I want you to remember one thing, guys. So हमने एक बात पढ़ी थी, that's a use dependence. ठीक है? Use dependence. There is one thing known as reverse use dependence. मतलब what is that? कि action potential is जो action potential prolongation है ना, action potential prolongation is least marked at fast rates. Fast rates whenever जो increase जो depolarize कर रहे हैं हमारे fiber जो topics हैं, उनमें अगर हम increase करते action potential duration, that would have been beneficial for us. ठीक है? But what is happening is I'm seeing the opposite effect. जितना ज्यादा कोई fast fiber है, उतना ज्यादा उसमें action potential prolongation कम हो रहा है. So this is known as reverse use dependence. And this is the thing जिसके कारण मुझे Torsades response हो सकता है. But one thing for sure is amiodarone is one drug. It is a class 3 drug, but इसमें reverse use dependence नहीं होता due to any mechanism we don't know. And why is that happening? I'm going to tell you that. तो amiodarone क्यों use करते हैं? It's a drug of choice in case of ventricular fibrillation. ठीक है? Ventricular fibrillation, ventricular flutter में it's a drug of choice. Treatment of choice obviously नहीं है. उसमें still your defibrillating shock will be one. ठीक है? So we can use amiodarone in case of ventricular flutter, ventricular fibrillation, and in case of a rhythm control in your atrial fibrillation and your atrial flutter. इसमें हम use कर सकते हैं. Amiodarone is a very good drug because it blocks multiple things. It can block your sodium channels. It can block your beta receptors. It can block your calcium receptors. It can even block your potassium channels, जो इसका main action है. And that is the reason why, because it has such a multitude of actions. That is the reason why there is low incidence of Torsades response. And it does not have any reverse use dependence. So that is the thing. Uses can, I already told you, rhythm control in atrial fibrillation, atrial flutter, and in case of your ventricular tachycardia and your ventricular fibrillation. So ये मेरे drugs preferred है. I can use it even in your WW tachyarrhythmias as well. ये मेरे सारे drugs हैं. That is your amiodarone. But एक problem थी amiodarone के साथ. ठीक है? What are the side effects of your amiodarone? It leads to pulmonary toxicity. That's one. Pulmonary fibrosis करता है ये. It can lead to gray-blue skin decolorization. That's known as the blue man syndrome. ठीक है? तो amiodarone is associated with blue man syndrome. It can lead to corneal microdeposits and halos in the eye. That's another thing. अब amiodarone की प्रॉब्लम क्या? आयोडीन. It's an iodarone है ना? आयोड आ रहा है इसके बीच में. It can lead to two things. या तो वो T4 से T3 conversion को रोक सकता है, and that can lead to hypothyroidism. Or the iodine which is present inside can lead to hypothyroidism. So both have been seen. However, hypothyroidism is much more common as compared to hypothyroidism. So इसके response में we discussed, we developed another drug, that is dronedrone. So this dronedrone has no thyrotoxicity. It has no pulmonary toxicity. Problem, it has a black box warning for your use in your stage 4 heart failure. ठीक है? So इसकी एक बस problem है, वरना इसके mechanism of action and your use is exactly similar as compared to your amiodarone with less amount of side effects. ठीक है? All right. Then we have some other drugs. They're not so important, guys. So next one is your class 4. That is your CCBs, calcium channel blockers, जो मेरे class 4. We know they're going to inhibit your L type of voltage gated calcium channels. भी हमें पता है ये, ठीक है? And mainly they're going to suppress the automaticity and the re-entry dependent on slow channel responses, जो mainly is more possible in case of your partial depolarized fibers. ठीक है? तो ये मेरे verapamil है. And why do I use verapamil? I just want you to remember PSVT में use कर सकते हैं, and we can use it in rate control in atrial fibrillation and atrial flutter. Because why? Because they decrease the AV node conduction. They're going to block the AV node. you're going to increase the effective reactive period of your AV node, and less amount of impulses are going to go from the supraventricular compartment into the ventricle. This करके I'm going to use it in PSVT or in case of atrial flutter and atrial fibrillation. मतलब सबके सब supraventricular tachyarrhythmias में I can use your verapamil. ठीक है? And I told you guys, CCBs are contraindicated in your WW syndrome. Digoxin is contraindicated in your WW syndrome. Beta blockers are contraindicated in your WW syndrome. और मैंने reason आपको बताया था that in some patients, 1/3 patients में this bundle of Kent might be less refractory as compared AV node. उन patient में क्या हो सकता है, in these patients if they develop microentry reentrant in your atria, that's known as micro reentrant tachycardia, तो उस atrial arrhythmia को क्या हो सकता है, when I give a drug which is going to block the AV node, सारे के सारे impulses are going to the bypass tract which has a lesser amount of refractive period as compared to the AV node. So that is not good. उसके कारण मेरे जो supraventricular tachycardia है या tachyarrhythmia, that can become a VT or VFI. So that is the reason I told you. I've already discussed in digoxin as well, so you can see that how pre-excited atrial fibrillation and flutter. If in patients में अगर I'm going to give a drug which is going to block the AV node, तो जो मेरा ये safe passage था, so मान लो for example 10 impulses were going, इसमें से 5 are going through the AV node and 5 are going through the bundle of Kent. But if I'm going to block the AV node, सारी की सारी impulses are going through the bundle of Kent. And bundle of Kent इस case में क्यों इतना dangerous है? Because in 1/3 patient it might have a shorter refractive period as compared to the AV node. ठीक है? So ये हमारा ये important thing थी. Diltiazem ने already बात किया था कि it has less amount of bradycardia and depression cardiac contractility as compared to verapamil, as well as vasodilation भी इनमें कम होती है. ठीक है? So that is your diltiazem. All right. The next drug that is we have adenosine. Okay, adenosine are going to work on your A1 receptors present on the SA node, AV node, and the atria. So you see, ventricles पे ज़्यादा इसका effect नहीं है. ठीक है, lidocaine का mainly effect कहाँ था? Mainly effect was in the ventricles. उसमें हमने supraventricular हमने lidocaine को नहीं यूज किया था. यहाँ पे we are doing the exact opposite. इसका ventricles में कोई ज़्यादा यूज नहीं है. इसका mainly supraventricular compartment में यूज है. How does it work? It's going to stimulate the opening of this acetylcholine sensitive potassium channel. ठीक है, it's invert rectifying potassium channel. इसके कारण hyperpolarization हो सकता है, and it has been also been seen to block some amount of calcium channels as well. So this is your adenosine. It has a very short t-half only of 10 seconds because it is जो uptake हो जाता है into your RBCs or endothelial cells, where this adenosine is rapidly converted into 5' adenosine monophosphate or inosine. ठीक है. And just remember guys, dipyridamol हमें पता है it can increase the action of the adenosine because it can prevent the reuptake as well as your degradation of your adenosine. ठीक है. Caffeine and theophylline, because they block the adenosine के receptor, they can decrease the action of this drug. तो इसके कारण supraventricular tachycardia अगर किसी caffeine addicted patient को होता है which consumes a lot of amount of caffeine, उस cases में adenosine का जो dosage है we might have to increase it. ठीक है. So what is the drug of choice? ये किस केस में? It's the drug of choice in case of paroxysmal supraventricular tachycardia. या तो वो AVRT के कारण हो सकते हैं और it can occur due to AVNRT. हमने already पढ़ा. ठीक है. What are its side effects? It can lead to flushing, it can lead to chest burning, shortness of breath, that is dyspnea, transient dyspnea हो सकता है, blood pressure कम हो सकता है, ventricular standstill and ventricular fibrillation are rare, and it can also precipitate your bronchospasms in case of your asthmatics because bronchodilation कराता है adenosine. तो अगर हम adenosine के receptors को block कर रहे हैं, that may lead to bronchoconstriction in this asthmatics. Right. So ivabradine हमने already पढ़ लिया. Ivabradine can also be used in case of symptomatic inappropriate tachycardia. ठीक है, beta blockers use कर सकते हैं, but where the beta blockers are contraindicated, we can use your ivabradine as well. ठीक है, right. We have some other drugs as well. We have ranolazine. It's again a sodium channel blocker. We can use that as well. All right. So ये हमारे सारे drugs हो गए हैं. So these are the different ones. And just look at this table very carefully and just choose the drugs. For example, PSVT के case में, I want you to remember adenosine is the drug of choice. We can use any AV nodal blocker. What are they? We can use verapamil and CCB. ये हमारे diltiazem हो गए, ये हमारे CCBs हो गए, ये हम block कर सकते हैं. Or we can use anti-adrenergic like esmolol अगर मुझे बहुत quick relief चाहिए. ठीक है. वरना अगर recurrence को prevent करने के लिए I can use oral preparations of verapamil, diltiazem, propranolol, sotalol, anything like that. When I want to talk about atrial fibrillation, उस case में मेरा answer treatment of choice will be DC cardioversion. ठीक है. So DC cardioversion is one. But अगर वरना और मेरे को अगर choose करना पड़े, then I can choose among all of these drugs. ठीक है. WPW में guys, just remember the treatment of choice is radio frequency ablation. उसे correct करना, जो bundle of Kent है उसे हटा देना. ठीक है. And जो मैं use कर सकता हूँ WPW में, that is your propafenol, procainamide can be used, amiodarone can be used, but don't forget we can't use anything that can block your AV nodal blockers. AV node block नहीं कर सकते हम, action potential effective refractive period of AV node नहीं prolong कर सकते in case of WPW syndrome. ठीक है. And हमने already बात किया VT में हमारे जो मेन ड्रग वेरी इंपॉर्टेंट है lidocaine बहुत अच्छा है, procainamide बहुत अच्छा है, and amiodarone is very good. So these are the ones. ठीक है. But just remember उस केस में भी the treatment choice is again cardioversion again. Right? ठीक है. All right, guys. So we have already finished your CVS pharmacology. ठीक है. I was thinking कि आज मैं किडनी वाले ड्रग्स भी आज कवर कर सकता हूँ, but I think I overshoot मेरे हो गया थोड़ा टाइम लिमिट. I'm going to stop today. इसके साथ already we have already covered all of this because ये diuretics and antidiuretics are not a part of your CVS pharmacology. But I wanted to discuss them because antihypertensives फिर हमें पढ़ने की जरूरत ना पड़ती. But I think antihypertensive you can read it all on your own. जो major amount of drugs we've already covered. जो kidney वाले drugs हैं, that is your diuretics and antidiuretics. I'll maybe club it with your GIT or your CNS, maybe any CNS lecture के साथ. ठीक है. So from आज basically we have covered 5 chapters of CVS pharmacology. So to me, CVS pharmacology is almost complete. All of the notes have been uploaded to your Telegram channel, so you can look through that as well. Make your own notes. And for anyone who is in the second year, thank you so much, Mangi. Thank you for conducting this session. Okay, so all of these videos are saved, so you can watch it at a later time. You can watch it at a later speed. You can increase the speed as well. You can take notes. I would prefer that you mainly focus on your books, Abibi, and I've already told you the books as well. So thank you so much for attending, guys, and I appreciate that you attend these lectures, and I hope that these are of some benefit to you. So I'll take my leave today, and thank you all for joining.